to be. Effectiveness is a kind of a measure that what is the time frame, how well, within what time, like cost effectiveness, or maybe it's a measure in terms with regards to time and with regards to maybe the other resource, how best managed resource, effective management, like that. I mean, in terms of resources, how well this product can be utilized.
Okay. Okay. So there were some keywords there, best. I mean, one thing that I want to, make, one is best. We'll talk about what best. Then time, time. Okay. We'll come to that. Yes.
Simple word. Efficacy means the effect of any intervention in particular given controlled condition. How best it can give, and effectiveness is practical thing. So effect of any intervention in practically available or existing situation and all parameters.
Okay, this is a useful definition. So okay, so you're measuring the outcomes. Okay, we are interested in measuring the effects of interventions on some outcomes. Now, which comes first, efficacy and effectiveness? Which has to be established first? Efficacy. So taking this concept to what Dr. Nitin pointed out is that when you have to establish the effect of any intervention, that intervention could be drug, it could be a vaccine, or it could be any public health intervention also. So you first measure the worth of that intervention in an ideal setting. Okay, whether really it can work in the best possible scenario that you give for an intervention to produce effect. When you measure that effect, that will be efficacy. Okay, so you are measuring efficacy. The randomized clinical control trials, which are the experimental studies, initially will try to establish the efficacy, the best effect that can be produced when everything goes in an ideal scenario. In real world, idealism is not achieved. We have a lot of variations, right? Okay, so when you measure the effect away from ideal but more of real life and real world scenarios, you are measuring effectiveness. So here the effect could be lower than what was being achieved when it was best. Is that okay? So there are two words, efficacy, effectiveness. In intervention research, when we are trying to establish the effect of the interventions, we first try to measure efficacy. If it is efficacious, we would also be interested to know its effectiveness. Is that okay? So COVID-19 vaccines, when first introduced, there were initial randomized controlled clinical trials, phase 3 trials, to give some data that yes, it can have some protection against SARS-CoV-2. Right? But that does not mean in real world also it will give that much protection. In real world, there'll be diabetics, there'll be hypertensives, there'll be obese, there'll be cancer patients, immunosuppressed patients. When they get the vaccine, what is going to be the effect? Maybe the trial did not include all these subjects, but in real world, they will also get the shots. Yes or no? The real effect then could be something else, what we achieved in those phase 3 clinical trials. Okay? So in real world, we get an effect of a measure of effectiveness, which could be different from what we see the effect in the best possible case. Is that okay? Clear? Everybody is clear about efficacy, everybody is clear about effectiveness, right? Okay, now let's see this. You must have heard this on first day. The treatment gap in mental health disorders as being established by National Mental Health Survey done 15-16. So the treatment gap is going to measure how much people who were suffering, but they were not getting the treatment, right? And what we see is all of these psychiatric conditions, bipolar, psychotic, manic depressive, neurosis, alcohol use, the treatment gap was more than 70%. Quite high treatment gap, yes, not a very good situation, right? So do we not know the treatment what is the treatment for anxiety, neurosis, depression, schizophrenia? Do we know what drugs are available? What is going to be really working against them? Yes, we have drugs, right? Right, we have drugs. So there are sufficient interventions available to treat them, but still there is a lot of treatment gap. Why? Okay, so we know there are drugs, but in real world there are many more factors that will really make the patient get those drugs. And then those jargon will come access, whether there is an access to a healthcare provider. Are there people available to treat these conditions? There is stigma. People do not come forward unless and until it's really, really a big suffering and somebody takes care that they should be treated now. Yes? So there are a variety of reasons why people are not getting the treatment. Right? It's not that we don't know the drugs. We know the drugs, we know the treatment, but that's not sufficient to make everybody in this world to get those drugs. Right? There are a lot of problems. Right? So there in the real world, there are determinants of not getting treatment. Okay. So in real world, if you have an efficacious drug or an intervention, it's not necessary that people are going to have an access to that. There could be problems related to access, right? Okay. Even if the people have an access, does not mean that the provider that they take or seek care from will be giving them the possible treatment. If that knowledge, if that healthcare provider is ignorant about the treatment or doesn't have sufficient skills, then also there'll be a gap. Even if the treatment is provided, it's not necessary that patient will also be compliant to your advice or the treatment. So there can be still a problem that patient is being advised something, but patient doesn't follow. All of this ultimately will reduce the effect, right? So efficacious becomes effectiveness, and there are a lot of factors that come in that scenario, right? Okay. Now in health system, we have many kind of processes, we have many kind of blocks. We have outpatient services, we have inpatient services, we have pharmacists, we have drugs, supplies, there are logistics, right? And then comes, our community things, outreach, there are NGOs, then there are, ASHA workers, there are so many kind of actors in the system. All of these people and the factors related to them also try to affect whether somebody receives right kind of intervention that can actually produce an effect. Is that okay? Right? There are a variety of these things which will affect the context that Dr. Shikha was talking about. Right? Okay. What do you see this? Suppose the first, this is one MO. Okay, this is one MO and this is another MO. MO1, MO2. Okay? And these bigger circles around this MO1, you see, could be CMO, could be SMO, could be some. Okay, factors in which that MO is working. And there are also some circles there around MO2. Now, what can you make out just by looking to this? Even if I don't say MO1, MO2, what is this figure telling you? What is the inference? What is the interpretation that should come? I want some volunteer to speak. Okay, this one is okay. We consider this as 1 and that is 2. Okay, if you're considering that as 1, okay, so okay, that one is 1, this is 2. So what is 1 doing? Okay, so in that one, towards the right, I mean the MO is a better influential to others, whereas on this towards the left, it's like the MO gets being influenced by the others. Any other interpretation? Okay, fine. So maybe when there are more circles surrounding bigger circles, that's not support coming, and there the support coming, so MO is flourishing. It's being nurtured. You want to say something?
Whereas in population, the awareness is less. But when awareness created by the MO, the responsibility MO is less and the responsibility of community is higher.
Okay, so maybe one of the circle is community circle surrounding that also is determining, the MO, whether it has to assume big or less. Okay. Okay. Okay, fine. So that's one interpretation. That's the perspective. That's fine. The bigger MO is autocratic, the other MO is not autocratic. Okay, fine. You want to say something? Yes.
On the right side, the MO is very active and there's more potential. Rather, he's not getting support from the external forces. Rather, in this, he's getting all the supports, but the MO is not capable of implementing those external support.
Okay, so now we are thinking about the capability of this MO, right? So maybe what support and what all for performance. Okay. Yes, last. Okay, you want to also say, okay.
On the right side is looking more effective.
As compared to left side, but if you see the dimension, the both are same efficacious. Efficacy might be same, but the effectiveness seems to be more on the right side due to various factors.
Okay, so MO is more, performing well, efficacious, where he is, yes, bigger circle inside. Yes, Srinath, tell.
Both of the oranges are actually same. Only that the surrounding circles make us look different. So both of the MOs are actually more efficacious, equally efficacious. So maybe the kind of charges they have a certain, the amount of charges.
So good. That was a very good concluding remark. Yes.
If it's a higher patient load per MO, the contact of the patients with the MO is decreasing, that is shown at the first one. If the second case, the patient load is less, the doctor will be able to give more time to them and they will be in a better contact with them.
Okay, fine. So we are assuming now one circle as patients. Outer circles is patients. Okay, so this is again an imagination. Okay, fine, good. So this is
hello. A request to the participants to use the mic because online participants are unable to hear the discussion.
okay. Yeah. So anyone in online wants to comment, and then we'll have the concluding. What it is about. Any online participant wants to say anything? Any raised hands or somebody wants to say?
Hello, Dr. Ankita, do you want to add anything to the discussion? Not yet.
Okay, okay, thanks. So thanks everyone. This is actually a psychological illusion as being described by, Evan Haas. Both the circles are equal in size, as rightly pointed out. Okay, but they are looking very different because of the influence and the size of the outer circles. And this is very, very important. And this is what is determining context. Okay, somebody who is affected by the layers surrounded by them, there will be differences, in many of the parameters, whether it is the performance or motivation to work, or willingness to work, and that actually, will affect a lot of services, right? So the message and the takeaway that we need to take from this is that anybody is affected and influenced by the layers outside. Okay, so in health system there are many layers, and performance is also going to be affected by all of these surrounding determinants. So you have inner layers, you have outer layers. The inner settings are those in which one is performing, maybe in an organization or a department that that person is working, will influence the functionality of that healthcare provider. There are also outer influencers, from other sectors and the governance, the larger picture, that also will affect, the performance of a healthcare provider or any individual for that matter. And then, of course, you have an intervention sitting in the middle that has to produce an effect. So the intervention to produce an effect is affected by many layers. Where it is delivered, who is delivering, in what setting it is delivered, and what are the influencing factors that govern the implementation. Is that okay? All of this will result in some results. Okay, whether best results, it's not that the intervention is not worthy of producing the effect, but where it is getting delivered will make the difference whether it produces the desired result or not. Okay, so there are many, many contextual factors, and context is important. We have culture, we have stakeholders, actors in the system, the health system factors, the geography, the access factors, the individual characteristics, the socio-economic characteristics. All of this ultimately will affect that somebody will get the intervention or not. And all of us, those who are practitioners in public health or in clinical medicine, realize that there are gaps in implementation. Okay, we are not able to do our best jobs because of a variety of reasons. Okay, so there is no to do gap. Okay, we know the interventions, but how do we take the interventions to all is that we do not know sufficiently. And this is what is the evidence that we want to have. Okay, and therefore now in a situation like this, the current situation wherein there are so many evidence-based interventions, I think there are many now. The challenge is how to take these interventions to the last mile is an issue that requires still resolution. We do not know the best strategies of making everyone get that intervention because of several barriers and gaps that exist in the system, right? So implementation research is a research that tries to bridge this no to do gap. Okay, so it is a scientific study, so it is scientific, that uses methods systematically to increase the uptake of evidence-based interventions, ultimately to improve the quality and effectiveness of the interventions. So here now we are talking about quality. So quality is another parameter that we are concerned with. We are concerned with coverage of interventions. Everybody should get the desired intervention so that the larger picture, the effect is more, the impact is better. Is that right? So this is what implementation research is all about in clinical and public health practice. So what are the principles of implementation research, or what does implementation research do? It tries to identify the implementation problems, number one. Number two, it tries to understand the factors that are related to these problems. So it determines the facilitating factors and the barriers that affect the implementation. After having all this knowledge, we want to devise some solutions so that we can enhance the delivery of these interventions. So we will have better implementation strategies. And ultimately, we learn from these strategies whether they are producing the desired results. If no, then we change the strategy again. And then iteratively, we try to achieve the best impact possible. Is that right? So that is what is the scope of implementation research, right? So the implementation research begins after we have established efficacy, after we have established effectiveness. Okay, it starts beyond that, that how do we take these effective interventions at scale? Clear to everyone? Yes? Okay, great. So this is very, very context specific. It is contextual. So it may be that what is true in Bihar may not be true in Kerala. What is true in Telangana may not be true in Uttar Pradesh. The problems are different, the governance is different, the context is different. And therefore, we need to have local solutions. How best to take those local solutions is the job of local people to get those solutions. Okay. This is real world, real time. It will be adaptive to the real changes that are occurring in the scenarios. It involves many stakeholders. When it comes to delivery of interventions at large, there are multiple actors involved. There are multiple stakeholders involved. Some are program managers, some are implementers, some are healthcare providers. So there are a variety of these actors, multiple stakeholders. It's multidisciplinary. It involves a lot of disciplines. Okay, so you may have social science expert, you may have program implementer, you may have a management person, you may have a biostatistician. It involves many. You may have an economist who looks after cost effectiveness. We talked about cost. That's also very important at the end for the policy people to know how much it is going to cost, change strategy. Okay, it focuses on processes. So there is a process that is involved, and ultimately it is this process which is very, very important. So those activities, how they are performed, who are performing, in what context they have to deliver, all that is going to define the process. And this process is very, very fundamental in knowledge of implementation research. And often this process is very loose. So you have to structure it better so that we can have good results. Okay. And all of this is ultimately going to shape your outcomes. Somebody said in the discussion, outcomes are very important. Yes, outcomes are, at the end, the outcomes are very important. Here, it's not just the medical and the service outcomes. We're also bothered about implementation outcomes. I'll talk about a bit later what these implementation outcomes are. Methods fit for the purpose. This line means it is not method specific. You have variety of methods in research. It depends what you want to do. So it is not that this particular method is only for implementation research. So whatever varieties of methods we have, whether it's quantitative research methods or the qualitative research methods, we can use combination, depends what we want to do. Okay, so methods are based on the purpose or the intent why you are carrying out a particular activity. And then it has to be relevant. It has to be solving the contextual concern, which is actually, a burning issue. How do we do it? How do we really, enhance the coverage, improve the delivery, improve the performance of workers, improve the quality, all that, right? Okay. So the questions that are addressed by implementation research are, which policy or intervention is best for the new context in which the intervention has to be delivered? What is the best way to implement it? How can all the people there in the target population be reached? So how do we bridge the prevailing inequities? What factors will affect the delivery of intervention or implementation of intervention? How can we reduce the cost of all of this implementation in best possible way? And how can these uptake and the health outcomes be ultimately improved? So all of these are scope of implementation research. Now I'll just illustrate this by one Kerala diabetes prevention program. I mean, this study started in 2013, and still, some of the studies are published, through this particular model that is there. So this is done by, Sri Chitra Institute with a lot of, stakeholders involved. So my aim, I'm not taking the entire results of this study to be told today, and you can read them. But what is that, how they approach this particular problem and how cultural adaptation was being done in the context of Kerala, where diabetes was very high. And they wanted a community-based, context-specific intervention, which should have the components of community engagement and community empowerment, and they utilize the peer-based approaches for lifestyle modification of people at risk for diabetes, right? So there were 3-4 parts to it, which is the implementation research cycle. So there are 4-5 parts that I'll illustrate in next few slides, and this is what was the approach that they did. So the first thing that they did was, what was the need? So they did a need assessment, situation analysis. They tried to understand the local context, the community awareness about diabetes. I mean, how people are being treated, what do they do locally to prevent its occurrence? Okay, and what they found that there was not much awareness at that time when they started the study, and not many community-based programs were being implemented. Based on this need assessment, which is a formative phase, they did set their objectives, that what they want to achieve. So they basically said that we want to do something as behavioral interventions to modify the environments of people so that they also become self-aware and they do some kind of lifestyle modification for themselves. They adapted the program from the available literature knowledge which was present, and they said a lot of behavioral change techniques require a local adaptation. So one of the things which we do in implementation research is the knowledge that we have, that what works, we will have to adapt it in our local setting, and then we will try to implement and see that there are better results or not. They piloted this intervention, they tested it, before really taking to some larger pockets. They said, okay, we will get the results from the pilot. They found that males were not getting forward for group formation. Maybe you require some more strategies to work with men compared to women. Men not available on regular days when they are out for work. Women were available, so they were easy captive population to do group work, to hold meetings, and to do a lot of advocacy and kind of behavior change sessions that they could do. And finally, when they refined with the learnings from the pilot, they said, okay, we will test it to a larger kind of pockets, and then we see whether we can have some desired results in terms of lifestyle modification and better diabetes prevention compared to a setting when there was none. So this program actually vested on a group-based peer support strategy for local community-based people. There was a peer leader training program that was being invested on, a lot of resources developed for selection of these peer leaders, and then they being trained so that they can actually empower the local people by having regular meetings, and larger community engagement and empowerment was being done. So this was a community-based study looking for a strategy. How can we reach people, in say rural or in urban settings? So this was a rural-based study, and then that's how they did it. Okay. So this is one example just to illustrate that there are multiple phases, and that's how an implementation research is being approached on. So this is not epidemiological research. This is not traditional randomized controlled clinical trials. This is not just simple monitoring and evaluation. It is beyond that. Monitoring and evaluation just tells us where are we, how are we performing, what are the gaps. It doesn't tell how do we have the solutions. What are the best solutions? So this is much more than monitoring and evaluation. And also some people, say there is operations research, which basically, talks about mathematical modeling, forecasting in a setting of COVID pandemic, how many beds you need. There's a lot of mathematical modeling, how many cases will occur, and then finally, how much is the situation. This requires a lot of mathematical modeling. So that is operations research. So this is also not that, right? So this is not all in the purview of implementation research. So let's see what is there. So as I mentioned, we start from that there is already an evidence on efficacy. We need to see whether there is an evidence on effectiveness or not. If there is no evidence on effectiveness, we may do some kind of a hybrid study that tests both the effectiveness and implementation. Otherwise, we will purely focus on implementation aspects, and we will study those implementation aspects. We'll design the strategies, we'll test the strategy, and then we'll study the outcomes. Is that right? Okay. So the foundation of this comes with theory of change. And we say that if this is being done with the stakeholders, and this is how the processes are being delivered, we will get better results. So these are assumptions. So we set a theory that if this is being done, this will lead to better results. So this is a theory which is an assumption of change, okay, which may not be true, which is the scope of research. The research will tell us this really works or not. It will have a model, okay, on which everything is going to be based. And largely, this model will also have a framework which will, tell us about the role, about different stakeholders that are going to be there. There are multiple frameworks that are in use when we actually, set a implementation research proposal. One of them is the consolidated framework for implementation research, which lays out what is the inner setting, what is the outer setting, who are the actors that are involved, what was the unadapted intervention, what is going to be adapted intervention, what processes are going to be taken up. So all of this is going to be talked about when we have this framework, which is a lot of constructs. It has around 39 constructs. A lot of detailing goes to understand the implementation processes here. We also have one other very useful framework, which is REAIM framework, which stands for reach, effectiveness, adoption, implementation, and maintenance. So we also build this kind of a framework, so we can use one of them depending upon which one is going to suit. There are others also like proceed, and many other deterministic frameworks that are there. So largely, we focus on implementation outcomes first. And when we talk about implementation outcomes, these outcomes are acceptability of the intervention. Is this really acceptable? If we deliver something, people are going to accept it. So that's an implementation outcome. Appropriateness, adoption of that particular intervention, feasibility, fidelity, cost, coverage, sustainability. So all these are the jargon that we use when it comes to implementation outcomes. Then comes, the service and the medical outcomes and the larger impact outcomes, which affect your effectiveness and ultimately the morbidity and mortality kind of outcomes. In any research, ethics is important. I mean, in today's scenario, no research can go without having ethical principles in place, right? So is true about implementation research, wherein we engage with human participants. So you have to respect for autonomy, rights, and dignity. Confidentiality is important. Informed consent, assent to minors, participant information sheets are very important to design them in a language that is understandable by them. Who is going to access data, how the data is going to be presented, everything is very, very important, and ethics committees will look onto all of these aspects. Well, this research has to have a societal benefit. It should do no harm, minimize all harms. It should address the inequities and have larger social justice benefits. It should reciprocate in terms by giving possible better solutions at future. And the research has to be accountable and transparent, and the results, whether positive or negative, have to be disseminated. It requires multiple stakeholder consent, because when you have so many actors being involved, they all have to, provide and agree to it. Well, this is a challenging area. Okay. 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 So when we are talking about this participant information sheets, if you, okay. So the question that is being asked is that in a setting wherein we are doing real world implementation, and we are going to providing the services, is it necessary to take these consent procedures? Now it's important to understand that these still are not routine practice, they are researchable strategies. So maybe the gatekeepers have to be informed and their consent has to be taken. So the program people who are there where the implementation has to be taking place, they need to be informed that such a change implementation strategy is there. Also, when you are holding these, say for example in that study of community meetings and all, you need to inform that you are being engaged as a research participant. We are testing a new strategy and we will do serial measurements and we will see the outcomes, right? So they are not yet totally adopted. Well, the answer to your question is not strictly yes and no, because there are some lines wherein we do it in real life situations. Suppose we do a quality improvement study in a routine hospital setting wherein the processes are done, but then we want to improve on these processes. Now, in real sense, you will not take the consent of each person who is getting the delivery, because you're changing the routine environment and you're just changing the practice of providers. But then the process itself is going to be an iterative, and to do that change process, you may have to get the ethics clearance also. So not all principles of kind of ethics, and this will actually pertain to the situation and the scenario for which you're working. But still, you can't say that I will not seek the ethics scrutiny for my proposal, because there are going to be researchers also being involved into it. And there has to be a synergy between the program implementation and the research process. I hope I have made some clarity on the concern that you raised. Clear, right? But still, the ethics is important. You can't say that just because that I'm implementing routinely, I can be unethical. I cannot be. Okay, right. And somebody has to safeguard that the rights of persons, and if the person say, no, I don't want to have a change strategy of implementation, the person has a right not to accept it too, right? Okay. So no coercion, voluntariness. Now, this is a combination of participatory action research, management, quality improvement, mixed methods. It's relatively new science, evolving science. Still, we are getting new models, new understandings, but I think we are at a better place now, where a lot of literature is known about and a lot of focus is being getting on implementation research. Public health interventions are complex. They're not simple interventions. So there are complexities, there are many players, there are many layers. So doing implementation research also on multiple layers is challenging. It's not that easy. It's complicated. It's time consuming. A lot of energy and enthusiasm and vigor is required designing these implementation strategies. And what we focus on is that there has to be co-creation and co-production with stakeholders. So stakeholder engagement at every step is very crucial, so that we get their inputs, solving their concerns and taking them along with us as we try to find out newer innovative solutions. You will require teams of program implementers. So implementers and those people who are in program setting, if it's a public health problem, are going to be very, very important, who are going to address these implementation concerns. They face these implementation challenges, so they have to be at centerpiece. Of course, this requires research skills and expertise, so we'll have to have partnerships and collaborations with academicians and researchers who are, well versed with these techniques. A lot of approvals are required, as I mentioned. If you're entering into some even routine implementation setting, I mean, there are some gatekeepers in that setting. So you have to take them on board and say that this is what we are trying to assess. These are adaptive designs. A lot of adaptation happens, and sometimes mid-course corrections happen. It requires a lot of capacity building, and I think there are a lot of efforts now to build the competencies of different teams. There are some useful resources one can lay hands on. I mean, we have tropical disease research, WHO, and multi-partner implementation research toolkit, which is a good resource to lay hands on. A lot of detailing of the steps that are there. Global Alliance for Chronic Diseases has an implementation science hub, very useful wealth of information, repository of material warehoused there. So please look onto that. And also King's College London, there's one website on implementation research, a lot of resources available. In times to come, we'll also host many of the implementation research workshops to build the capacities of people like all of you, so that you can be trained. And in times to come, we hope that you will also practice implementation research. So thank you. If there are any concerns, it's time to ask. Yes, there is an overlap between behavioral change, modification, and many of the, implementation research projects now involve the component of behavior change. And in fact, many of the public health interventions actually have behavior change. So if you want tobacco, people who are consumers of tobacco, who should be motivated not to consume tobacco, it requires a behavior change. If you want people to remove stigma and to get to the healthcare providers without no shame involved, there is a behavior change. So behavior change is very critical in acceptability, in making people accept, either that there is a problem or that some solution has to be there. So there is an overlap between, but what we need to understand over here is that our larger context in which the behavior change has to be implemented, that is basically the larger implementation research picture. Yes, as a bigger circle. I mean, it depends on which problem you are addressing. If that problem requires a behavior change, definitely it will be a part of that. Okay.
So we did this WASH implementation research. That has a very big bearing on behavioral change. So like open fieldification and all these things. So it is actually inbuilt, I think, the behavioral change and implementation. Depends on the strategy and what you're implementing. Hand washing in COVID, I guess that equally had a good behavioral aspect.
Yes. Making people accept the vaccines. There's a lot of vaccine hesitancy. All of this requires a behavior change. I mean, in UP for polio, we did with Malvis. We engaged them how to get into those communities so that they get this oral polio vaccine. Yeah. Okay. What else? Anything else?
This thing, like you said, best solution. Is it always the best solution? I guess we have to kind of optimize. So the word best preferably is not.
So the best, when you mentioned, the best is only for efficacy. Okay, so in real world there is no best. Okay, so at that time when you were defining best, you were only actually relating to the efficacy. In real world, you will have to do a lot of deviations from best to see that at least we optimally, reach to get some desired result. Yeah. Okay. Right. No further comments or questions or remarks. So thank you all. I think we'll have the flavor of this also, when the group on implementation research is also going to talk about it. So you will have one more case study when those are going to talk about. Thank you.
Thank you, sir, for walking us through implementation research. Next, we have a session by Dr. Shankar Pinja. Sir is professor in Department of Community Medicine, School of Public Health, PGI, Chandigarh. We will be playing a pre-recorded video for sir's presentation.
Of the money that we are spending. So in this slide, I'm going to demonstrate to you that how the application of cost effectiveness analysis helps to make the outcomes of the health system more efficient. So on the y-axis, what you see here is the health benefit of interventions per $100,000. That means if you are here, that means the intervention is more cost effective, whereas if you are lower, then that means that the intervention is less cost effective.
There is a
So as you see,
record.
the interventions right now are ranked from a level that is.
We'll start the recording again because the online candidates weren't able to hear. So please bear with that.
An analysis of cost effectiveness can be applied to the context of answering a policy question around cervical cancer screening. And then towards the end of my presentation, I'll talk briefly about the development of health technology assessment in India, which tries to set up institutionalized systems of evaluating interventions on account of cost effectiveness. So to begin with, the three major strategies for financing universal health coverage that were outlined by the World Health Organization in the World Health Report of 2010 actually said that there are three mechanisms to finance universal health coverage. The first is obviously we need more money for health. So in one of my previous lectures, I did try to demonstrate to you that given the amount of burden that we have for non-communicable diseases, the amount of money that is allocated is much less. So we actually need much more than what is the current allocations on NCDs as well as on health as overall. The second is that we need to change the overall mechanisms of financing health from a high reliance on out-of-pocket expenditure that currently prevails to a situation where healthcare services are funded by the government through tax financing. But the third more important recommendation is that there is a need to reduce or eliminate the inefficient use of resources. That means we not just want more money for health, but we also want more health for the money that we invest in. So which means that there should be a rational allocation of resources whereby we are able to make the best value of the money that we are spending. So in this slide, I'm going to demonstrate to you that how the application of cost effectiveness analysis helps to make the outcomes of the health system more efficient. So on the y-axis, what you see here is the health benefit of interventions per $100,000. That means if you are here, that means the intervention is more cost effective, whereas if you are lower, then that means that the intervention is less cost effective. So as you see, the interventions right now are ranked from a level that is the most cost effective intervention to the ones that are the least cost effective interventions. So you plan your services in a way that you choose first and implement first the intervention that is the most cost effective and follow it up with lesser and lesser cost effective interventions. And you reach till a point that your overall budget gets exhausted. So at this point you actually stop and you are no longer now able to invest in any other intervention. So that's where you currently are. But what happens the next year, for example, there might be new interventions that might be available, new drugs, new ways of implementing programs, etc. And if that is but when you see that, there might be some interventions that may be more cost effective than the existing interventions. So in this particular case, the first two set of interventions are more cost effective than the existing interventions, whereas the last two set of interventions are actually worse than the current set of technologies or services. So obviously, if we are to make a choice, then we would not implement these two interventions, but we would like to incorporate these two in our benefit package. That means we would like to include these in our NCD program. But because our budget, let's assume it is finite, our budget remains the same, we don't have a change in the overall budget. So if we have to incorporate either of these interventions, then we have to replace some of these interventions that are currently in our benefit package, but which are less cost effective than each of these. So let's take one of these interventions inside the benefit package, and when we do that, we have to actually displace some of the less cost effective interventions from our program. And we do the same for the second intervention as well, and then we displace another few set of interventions from our benefit package. Now what we are left with are a set of interventions now that are part of our NCD program that have a much higher level of health benefit that is being offered per $100,000 that are being invested. Now mind you, we are within the same amount of budget that we were operating earlier, but now we have this as the set of interventions that we are implementing, and this is the total net benefit. The area under the shaded area is what represents the total health benefit that we are able to achieve, whereas the part here which is represented by this black shaded line is the one that was the original set of interventions that we had planned. So in a way, this yellow shaded part is the net health gain that we are able to achieve using the application of health technology assessment. So within the same amount of budget, we have been able to expand the overall level of health that we can achieve without even spending more. So that's how the health technology assessment or use of cost effectiveness assessment helps to guide policy towards making your net societal gains in terms of healthcare. Now, where are we in terms of our status for implementation of HTA in India? So in India, we have established an institutional framework for carrying out such cost effectiveness analysis and health technology assessments. So there has been a board that has been created at the national level, which is within the secretariat of which is within the Department of Health Research. And this has had some history behind it. So there was a recommendation for introduction of health technology assessment as a way towards guiding clinical treatment and policy in the 12th five-year plan that we had, which was then again reinforced in the national health policy that was drafted in 2015 and came in 2017. And as a result, in 2016, the HTAIN or health technology assessment in India was established, and the board was approved, which was earlier known as the Medical Technology Assessment Board, but now has been renamed to Health Technology Assessment Board. And the current status is that we actually have a draft bill that is proposed to be tabled in the Indian Parliament for creation of Health Technology Assessment Act, which would mandate powers to the HTA board in order to recommend interventions to different stakeholders, including implementers such as ministries of health, or regulators such as pharmaceutical pricing authorities, or the clinical bodies that develop standard treatment guidelines. So the process in which the decision making takes place is that the secretariat of the HTA board, which is in the Department of Health Research, invites nominations of topics on which assessments need to be done. And these are topics that are submitted by a range of different stakeholders that are mostly public sector organizations, either implementing bodies such as the Ministry of Health at the central level or the state ministries of health, or these or could be the National Health Authority that implements the PMJY program, or these are regulatory bodies like the Pharmaceutical Pricing Authority. And these are also technical assistance arms such as the NHSRC, which identifies topics, and these topics are mostly new programs, new drugs, new devices that the implementing bodies or the regulatory bodies think are likely to be subject to discussion or debate in terms of introduction in the times to come. So these are topics that are submitted to the HTIN, and then the HTIN then takes a call through its technical appraisal committee on whether or not these topics are worth investment to undertake a full HTA. And then based on the assessment of the technical appraisal committee, these topics are then commissioned to either of the different regional resource centers or technical partners that have been established with funding support from the Department of Health Research in different academic institutions and research bodies that across India. So one of the first regional resource centers that was established was within PGI Chandigarh in the Department of Community Medicine and School of Public Health. But besides that, there are now more than 13 regional resource centers and more than 10 to 12 technical partners that have been identified and that conduct HTA assessments on behalf of the HTIN. One of the examples that I would like to quote to you is the example of the study on cost effectiveness of strategies for cervical cancer prevention in India that we undertook. And as part of this assessment, we basically tried to look at that what is the health impact of introduction of screening, and the screening, as we see that if you were to question that what should be the way in which you should screen or organize a program for screening, then it boils down to three different questions. One, what should be the method that you should be using? So should it be VIA, cytology, or HPV DNA? How frequently should you be screening? Should it be like 3 years, 5 years, 10 years, or something like once in a lifetime? And what should be the population age group of women who should be screened? So should it be 30 to 65 years, or should it be longer or shorter duration? So we evaluated all these possible scenarios in which screening program could be possibly organized, And then we tried quantifying the health impact of each of these possible scenarios in terms of either the cases that are likely to be averted for cervical cancer, or the deaths that can be averted, or the gains that you can have in terms of life years and quality adjusted life years. And broadly speaking, the message that you get from this slide is, and these are values that are represented in terms of gains that you can have in a cohort of 100,000 women who could be of 30 to 65 years, who are screened starting from the point that they get at the age of 30 years, and they're screened up till they reach 65 years of age. So each of these strategies, if you compare, the clinical effectiveness in terms of the gain in health outcomes are maximal for the HPV DNA test, followed by the use of VIA, and the least outcomes that can be achieved are in terms of use of cytology. So that's the broad message that comes out of this study, this slide. But then you also are not just considering the clinical effectiveness or the health gains that you are able to achieve, you also want to consider how much is the cost of incurring that. And there again we compare a scenario where you don't screen at all versus you have all these possible different scenarios for organizing a screening program. And then there is a cost that is attached to screening. There is a cost on account of treatment of those who are found positive, which ultimately involves the total cost. So if you look at this now, the highest cost would be incurred if you organize a screening program using HPV test. The second in order is a screening program that might be organized with using the cytology as the method of testing. And the cost is going to be least if you use VIA as a method of screening. And when we use this together, the evidence on cost and the evidence on effects, then ultimately what the method that we find as the most cost effective is VIA if done every 5 years. So this method of VIA done every 5 years results in the maximum amount of health outcomes that can be gained at a cost that is less than the threshold that is considered as cost effective in India. So HPV DNA may be leading to much more higher health outcomes, but the cost that is involved in rolling out such a program is way beyond what would be considered as something cost effective in India. We didn't just only limit to this kind of an analysis, but we also tried to show that the screening is not just limited to identifying people who are having the problem, but it is also necessary to treat those who are found positive, because a lot of times programs for screening ultimately end at the point of detection, and there is not much attention that is paid to linking those who are found positive with appropriate treatment facilities. So what we showed was that even the test, which is VIA done every 5 years, which we found as the most cost effective, would no longer be cost effective if the coverage of treatment falls below 30%. So if the coverage of treatment falls below 30%, then even your most cost effective strategy for screening no longer remains cost effective and it becomes cost ineffective. And if you keep increasing the coverage of treatment for those who are found positive, then you keep increasing the efficiency of the overall screening program. So the cost effectiveness ratio keeps falling down as you increase the coverage of the treatment. We also tried investigating the question around HPV vaccination, and we found that if you introduce HPV vaccination versus if you don't vaccinate the adolescent girls for HPV, introduction of HPV vaccination is a very cost-effective intervention. This was our overall conclusion. But vaccination and screening are not mutually exclusive interventions. These have to be considered as two separate set of interventions that have to be given independently among the women or among the adolescent girls for the overall prevention of cervical cancer. And if you consider that, then a scenario that includes both vaccination of adolescent girls followed by screening starting from the point that they reach 30 years of age was considered as the most cost-effective strategy for prevention of cervical cancer. But there's another interesting aspect to this analysis, and that is that if you increase the coverage of your vaccination among adolescent girls, and if you reach a level that is above 70%, then you can your screening that is done with VIA every 5 years no longer remains cost effective, and actually now the screening done every 10 years becomes cost effective. So what it means that if you are able to achieve high levels of coverage for vaccination, you can actually reduce the frequency with which you organize your screening program. So that's again a very important recommendation that emerges from your assessment of the health technology to guide the policy in order to make your outcomes more efficient. Now there are a number of sources that are available from which you can, as program managers of NCD programs, you can identify that which are the interventions that are more cost effective. So one option for you obviously is that you can identify one of the regional resource center that comes in your vicinity, and you can approach the regional resource center and nominate a topic on which assessment could be undertaken. Or you could independently write to the secretariat of the HDIN in the Department of Health Research and nominate a topic on which you and the state in a given state want a particular intervention to be evaluated for. But besides that, at the global level, there are a number of sources from which you can access information on cost effectiveness of NCD interventions. And I've listed just 3 of them. So the first is the Global Action Plan for Non-Communicable Diseases, and it includes as an annexure a list of summary of the intervention, the cost effectiveness of the different interventions. Besides that, there is the Disease Control Priorities Project, the DCP, which was the 3rd edition of which was published a few years back, has separate volumes that caters to cardiovascular diseases, another volume that is for mental health, a volume that is for specifically dedicated to injuries, etc. So you can refer to each of these volumes to identify the evidence on cost effectiveness of different types of interventions. And finally, the Tufts University in the US maintains a registry of data that captures all the studies that have been published on measuring the cost per QALY gained with different interventions. So this is another registry that you could refer to in order to assess that what is the cost effectiveness of different types of interventions. So these are pieces of important repositories or data or sources of information that you can access in order to plan your programs. Thank you very much. This is all that I wanted to talk about. Happy to answer any questions later on. Thank you.
For any questions, no, sir. Because sir is not there with us. If there are any questions, you can just add in the group. We can revert back later. We will be rejoining for the group work after a brief mobility break. Yes.
Community visit, because these are the hard to reach areas, particularly the Koraput district, and it's also a forest dense area. So we want to estimate the cost for the, we want to put the cost for community visits also, and engage NGOs, because the doctor MOs, he may be from a outer area, he may be posted from via UPSC, so he may be not well known to that area. So identifying a local NGO who works there in the tribal area is, must also be considered, and ensuring essential medicine and diagnostics, because after screening, if you're not having enough supplies to treat or treat the patient, you cannot do that. So essential supply chain must be maintained, and digital NCD solutions. For example, since I said hard to reach area, for example, if any patient wants to get an emergency advice, he can contact through telemedicine like e-Sanjeevani platform or any other thing. So we want to input digital solutions also. So then coming to the process, so how budgeting will be, like budgeting will be for the concept of evening clinics, because since males are examined low compared to the females, so we thought that it could be because the male is a working population, they may not be available during the OPD hours. So we want to target them during the evening hours. So we want to develop a concept of evening clinics. So budgeting is necessary for that, and also for the mobility cost. Sorry for the typo, and for the incentives to given to the NGOs to run this process, and the healthcare workers, and trainings as such. We also want to train the service provider, like how to find the NGOs are not medical people, so we want to train them how to screen and how to identify a person, patient of hypertension, and we want to also ensure adequate logistics, and we want to organize health camps, particularly during Sundays and holidays for people going far away for work, so that we don't miss out any population, and ensuring systematic supply chain, as I said, and setting up cabins with good internet connectivity for telemedicine services, and critical review to develop appropriate IAC materials. So these all we want to include in the process. The next, what is the output of these process? So the partnership with NGO is developed acutely, and we also want to have quarterly meetings with NGO to get regularly updated with them and to educate them regarding the updated information. We also want to have a regular training with them, and the resultant of critical review for IAC materials are like, for example, you can take this poster, so that the male, there is no inequality in NCD services to males. It may not be gender specific, but we don't want to miss on the male population, so we want to try all this. So what will be the outcome? I would like to divide the outcomes, I mean discuss the outcome in 3 formats, that is a short term, intermediate, and the long term. The short term could be like increase in the awareness of the screening and partnership with NGOs and the increased coverage of services. So that could be the short term outcome. The intermediate outcome could be the risk reduction, the increase in the drug availability, and increase in the people receiving the treatment. And the long term outcome could be in the form of a target, like we are arbitrarily setting a point that 50% increase in the screening, 50% increase in the hypertension detection among males, and 50% increase in the number of males getting treatment. So these are targets with reference to the baseline data, which is collected via the, various sources, which I'm going to mention later. So the data sources to measure these indicators for the baseline purpose is the NCD application, the NCD MO portal, the performance report. Is from the if these 3 we are not able to, if we are not able to retrieve the information from these 3, then we'll go for the ASHAs to get the list. They may have the list of NCD patients, but even if they are not having the list, then we'll go for house to house surveys, so that we have a baseline data. Then, so what are the strategies? Coming to the strategies to reduce these inequities. So this is especially customized for Koraput. So coming to the human resources, that we have to train the male community health workers to identify males with NCDs. Why male? Because they might be males do not have access to that, and they may have security reasons. So we want to reach those isolated working areas for males also. So that's why male community health workers, and training NGOs and encouraging them to adapt a referral role. Like if they had doubt the person can be a pre-hypertensive patient or he needs treatment, like we have to we have to train them and recruit eligible people in some NGOs, so they adapt a referral role. Then coming to the infrastructure, so we have to increase the capacity of the tribal health and wellness center for screening, diagnosis, and treatment in the evening time, because in tribal area there may not be electricity for the health and wellness centers in the so it may be difficult to run the health and wellness center in the evening time. So we have to increase the capacity. Then help desk to support the tribal patients with a person well versed in the tribal dialect. The MO may not be well versed in the tribal dialect, so we want to have a help desk also. Then use the MOTA fund, that is the Ministry of Tribal Affairs fund, which is there. We want to use that for this infrastructure purposes. So how can we, then coming to the service provision, how can we give? It can be given in the form of mobile outreach, which can be at least once in a month, with all the diagnostics and medicine for the hypertension, along with health education on spot. And we can conduct periodic diagnostic camps with specialized doctors. Actually, in Koraput, Sir said he has a first-hand experience. There are many rivers running in between, and it's very difficult to access that population. So they have the concept of boat ambulance. What happens there is, so the boat goes from the main plain area to the mountain area, stays there with the group of doctor, pharmacist, health attendant, and the driver, and it stays there for 7 days, and they screen the population, and they come back. And they stay for 10 days, they come back, and after taking break for 7 days, again they go back to the same place for follow-up and other services. So we want to have, we can use that opportunity for mobilizing specialist doctor once in a month. And transportation of health workers, as I already mentioned, boat ambulance or bike ambulance in hard to reach areas, etc. And also the technologies, the telemedicine services, GPS, like telemedicine service in the form of eSanjeevani, and GPS to ensure the safety, because there might be safety issues in the dense forest areas and the tribal population. So, so that we can spot the emergency with the use of GPS. We can track the health workers, and health literacy drive, which must be culturally sensitive, customized to the tribal population of the Koraput district. And we can also get, active support and participation from Gram Sabha and key community influencers. After all, whatever we design, it should be accepted by the local community and it should receive the public support. So once we go through the Gram Sabha and the community influencers, we will be successful in this. And we can have annual health assembly, tribal health assembly for local planning, management, and accountability. We can also use that session for getting feedback. So coming to the implementation plan, how we are going to implement this. So basically we will do the area mapping and the need assessment of the area. Then we'll engage the village head and club, so that as I mentioned, we'll gain the public support. And then we'll identify the eligible male volunteers and service delivery personnel from any of the NGOs or NGOs. Then we'll scale up the existing case detection and treatment. Like I said, we can improve the extra infrastructure of the already existing tribal health and facility, health and wellness center. And we can also pilot evening OPDs there. And later, if it is successful, after getting the feedback and modifying it, we can expand it in a phased manner across all the across all the areas of the Koraput district. Then the monitoring framework. So the objective of the monitoring is to increase the diagnosis and treatment among males who are screened in the Koraput district. So who will be doing this monitoring? So it will be done with the help of the district monitoring and the evaluation officer. And we will be monitoring the outcome indicators. Like it can be both the qualitative or the quantitative indicators. Here we are here mentioned the quantitative indicators in the form of proportion of diagnosis among males, proportion of treatment among males, because we saw the lag. We already saw in that square that screening component is same in both the males and the females. Only the diagnosis and the treatment part is relative. There is, inequalities exist in that part. So we want to find the proportion, improve the proportion of males in that part, and rate of males attending the outreach camps. Because after investing so much, if there is no footfall in that camps, it's just waste of money. So we want to ensure by this monitoring, and the percentage increase among males before and after organizing camps. So these are all the quantitative indicators we want to evaluate, and there can be qualitative qualitative assessment in the form of in-depth interviews or focus group FGDs. So or NGTK with nominal group technique along with the district officials. So these can be done. So these can be, the simple FGDs can be done. May not be every month, maybe for once in a 3 month, once in 5 months. That can be done to assess the gaps and fulfill it. Thank you.
We start from them or we start from here?
Start from them first. Any comments from anyone in the group besides the group one?
Hello. Hello. Hello.
Hello. Good morning. Very nice presentation by the team one, and all the parameters have been included. The slides are very good. My only submission, we can do the root cause analysis for finding out the quality, and we can also have the supportive supervision and behavior change communication in this implementation plan. Okay. Thank you.
Thank you for the input.
I just wanted to congratulate the team one from my side, because the presentation is very good and we need to see the other presentations as well. And my critical appraisal would be the hard to reach area, tribal area, how far you can establish the good internet facility centers for e-Sanjeevani, where government is not able to be being provided with, even in rural PHCs, we are not having that. So hubs are also to be identified, where the doctors also should be available. And in the hubs also, you cannot have more than something like 5 to 6 specialties, specialist doctors always available. So there are
Definitely,
some
sir.
things
These are
which
the
are
challenges.
challenges.
Yeah.
Yes. Thank you.
Yeah, again, congratulating you for a very nice presentation. Very nice takeoff for all of us. I had just a few observations, and these observations stem out only because I know Koraput very well, and I am from Orissa. So
Sure,
perhaps
ma'am. We have experts here who have first-hand experience in
Yeah.
Koraput district.
so I share too some experience from therein. Basically, when we and that I leave the judges to opine on this, that when we kind of devise interventions to address equity, your interventions have been are primarily focused on the males, right?
Yes.
So, but don't you think that if you do that
Hello,
kind of a
hello.
male-oriented
No,
intervention,
as I already said, in between
Yeah.
I said it is not gender specific.
Hello,
Rather, it can
hello.
be like females can also access the
no, but
evening
your
clinics.
indicators, your whatever the intervention that you're doing, and
Yes.
all your indicators, outcome processes, they were like to pick
Hello,
up on the
hello.
male participation.
Definitely.
So ultimately, what would happen is like perhaps you would now get a skewed presentation in terms of having more males than the females. So what I feel that a gender, there should be a equity in your intervention too. Somewhere you could utilize the females who are coming in for screening and diagnosis as champions, because you know the women have most influence on the men folk. So you could have used that bit a little into
So,
your this.
Yeah, what you're saying is right. But if I use that, then there will be a lot of weight. Then I can take the caste, tribe, income. Lot of things come together because screening is, as you've seen, among the 31 percentage of prevalent populations, only 28.6% is screened. So we can have lots of discussion of increasing both the screening. But what we wanted to present is that we want to find the inequity part between the males and females. That's why our presentation is.
You want to be very focused. And
Yeah,
very
yeah, yeah.
centered on
Otherwise, we
improving
can talk.
the
It
males.
will be presentation will be going
Yeah,
for an hour.
yeah, but I feel that I mean, bringing the women also and making it a gender parity based intervention
Yes.
would be more appropriate, especially in a tribal area. And if you really go into the dynamics of the tribal people, they have a more of matriarchal family. Now, these things I'm telling because I know that place well. So they have a lot of, the tribal women, they lead. They are quite, like demanding, and mostly the women, the men are into addiction, and it's the women folk who, have to. Maybe the reason why they go in for management is because they have to, manage the income in the house, and the men are all resting. These are all observations. I am not kind of contradicting your slides. These are.
We were supposed to find inequities in other fields also, but the issue was we couldn't fetch data on everything. Like, suppose
Tribal data was not enough that we could
I'm
get
just
it
trying to
segregated. No,
Give it
the-
a
the-
overview. And the next thing is the evening clinics.
Yes.
So the evening, everything is shut in the tribal area. So I doubt if you would really get an outfall, and if that, you can use it as an advantage. Because evening also, like I'm working for the TV program there, elephants start coming out after 5 o'clock.
Okay.
So I don't know. He must be knowing that. It might be knowing about that. So evening is really not a very good option to optimize. These are just suggestions. I'm
Yeah,
not
sure.
really- Maybe yours will go very
Online participants, if you can switch over your video. Online participants.
ask for any observations.
Any comment from your side?
I want to congratulate Group 1 for a wonderful presentation.
Okay. Buddy, others, you want to say something?
Yeah, it's really encouraging to see that the group has put in a lot of effort in this. Not only the presentation, definitely presentation was more than what we expected, but also in the in the background work. I think within this short time you've been able to collect this much of data. That itself shows that you have put in a lot of effort to collect the background data and then try to find out the inequities. And the pleasant surprise which I found in this group is that you are focused on men. Generally, when we talk about inequities, we only think of women as a disadvantaged group. And I was thinking maybe you would talk about rural women, but then it turned out to be men. So yeah, and when we see in the program, this is one neglected group of people that we often, we just take it for granted that all our programs will be addressed to the population above 30. But correctly, you have identified that the men are actually not able to access the services. They are not being reached for whatever reasons. They are working population, or they are more less likely to seek care. But I think this is really a very good proposal that you've, and I hope that you'll be able to implement it somewhere, not only just in paper, and you can improve on that. And regarding that electricity problem, I'm just thinking out of the thing. Could it maybe could you think of using maybe solar powered thing? Some kind of solar energies, something like that. Internet, and yeah, once electricity is there, I think the things will also be easier to do. But I mean, that's just one observation. I mean, because that will be one crucial part. In the evenings, people will not like to go out in the night and all this thing. I mean, generally it gets dark very early also that side, no? So that is one thing. If not in the evenings, as you said, there are a lot of other dangers around. So maybe in the holidays or Sundays, that is also a good idea. But definitely we should look for this more. That is for physical interaction. But if we have, we can develop the other means, for example, medicine or teleconsultation. I think we should promote that in a much more. I mean, those have to be promoted much more rather than waiting for a medical team to actually reach those places. So yeah, that's all from my side. Thank you. Very good.
Usual practices, males are usually in the daytime, they take alcohol and sleep. So that may be the reason they are not accessing the health screening. That's why we have planned, because in the tribal population, they usually relax in the evening time. So they can spend one day in the evening for health, like a village health day. So all will come, the community leader, they will motivate them so that we can access the males and we can educate them and motivate them to come for screening. That's why we are planning for.
So that's why you need to know the local culture practices which are there rather than just giving general recommendations. No, that's good. Oh, that's very interesting. I thought they were working, that's why they are not able to.
And I have a little interesting addition to that. In Koraput, they did try the solar this thing equipments, at least for the vaccine management. But the interesting thing is that the tribals got so excited with the solar setup that they stole off all the plates, and even it attracted the attention of monkeys. I was a vaccine manager, so when I actually got to see a total disassembled setup, and it was more like costing or budget provoking for the system, for the health system to maintain that solar setup. So they're very interesting instances in Koraput.
Yeah. Yeah, I think it's really commendable, the group effort, and it was well evident with the very good presentation skills. I think setting the standard for other groups, so really worth appreciating the effort. And the topic that the group also took, I mean, it's really nice to see that men are also in focus, because it's so much I think women centric jargon always in talk. So sometimes I mean, it's difficult to talk about the needs of the men because women has taken all the needs for themselves, and they always make it a point that, you know, they're always on the tables and discuss. But men also have needs, and I think the indicators do talk about that there is a poor coverage as they illustrated. So the approaches that we are discussing right now will demand some feasibility, right? Like if they sleep in the daytime, will they be willing to come in the evening time? And also the feasibility of the health teams to be available during that time, because they also require security and other aspects to be taken care. So this will require some feasibility before actually, you know, you will dwell into what strategy is going to work. You focus on hypertension only in your presentation, and of course, I mean, that's the most easy thing to do because even the diabetes screening requires logistics, and if the supplies are an issue, but the program talks about, you know, 2-3 disease conditions. One just observation is that I think everybody should appreciate there is a difference between equality and equity. And I saw that it was used interchangeably. It is not, both are not same. Okay, equality means everybody is equal. Equity has a basic principle that everybody is not equal. There are differences. There are differences in needs. So when we are assuming men are different from women, we say that, you know, they are working. I mean, the traditional approach of thinking is that they're working. So that's why we have an evening OPD for them. Or we catch them on Sundays or holidays. Women are at home. So whenever the A&M Asha visit, they are there and we are able to. So there is a difference there between the way we can approach. Similarly, you know, income is one equity. So economic, financial indicators. Geography is an inequity. You know, somebody is living in a tribal area or a forest versus an island or you know, any difficult area for that matter. I mean, they are kind of different people than the others who are living in mainland. So there are differences, and equity appreciates that taking cognizance of these differences, we need to address them. Right? So equality generally will make them equal. Equity appreciates there is a difference and you have to act according to the difference. So this is what is addressing inequities. And one of the very important aspect which was brought about is that data has to speak. So if there is no data to capture those inequities, we will not be able to address that also. So the first step is to start collecting data by segregations because of the various prevailing possible inequities that are there. So very, very nice effort. I think we are thinking about addressing these issues in difficult areas. Of course, all of this cannot be realized. It has to be tested, and only then one can frame, you know, what works and what does not work.
I think a lot has been said till now, but the dynamism of the group, I think it's reflected in the presentation. So I must congratulate the group for this dynamism. And we have heard in the morning regarding implementation research. So this is a good area for the implementation research, and we should not be too ambitious in addressing all the issues in one go. As mentioned by Dr. Sumit, the tribal, non-tribal itself has an equity issue. So if we able to address that in terms of coverage, in terms of this thing, that is our first step to move forward for gender-based inequity. And in the generic comment, most of the time when we try to address equity issues, we go overboard and create more equity-based issues that we have seen across the globe from many interventions. But hopefully you will taken up, this group can take this idea further and develop a good proposal for any funding. It's a good idea. Thank you.
Not much from my side, just 2 points. I think as already said that we need to understand what drives that equity. For example, root cause analysis. A good understanding of why there is gender difference will lead to a better strategy, which is specific. So maybe a slide which maybe as a judgment, as a discussion, this is the reasons we think men are, because largely saying evening OPDs and Sundays are, to me, it appears like a more urban based solution where people go to work. I'm not sure in Koraput, being a tribal, there is a lot of employed people in offices. it seems to be more of a rural and so that might need a slightly different strategy. My only second point is that people should start looking at data, especially state program officers. The idea is that you will start looking at data available within your system to identify areas which have poor coverage or subgroups which have poor coverage, whether by gender, by income, and then make strategies to understand why those equities are there, and then make strategies to address those inequities. That's all. Thank you. Good work, and I again appreciate the quality of presentation.
I thank all the team members who gave their sincere inputs, and I also thank Dr. Ankit and Dr. Anand sir for being the backbone and giving the inputs and scrutinizing the presentation. Thank you.
We'll now move to
All group one want to come here. Yeah. Maybe we can do for every group. They all can come. I have a photograph. Okay, I didn't. Okay. Group two is the online group. क्या है?
we will be now moving to group 2.
Good morning, everyone. Am I audible?
Yes, ma'am, you are audible.
So, Abhishek, are you going to scroll down the slides or?
Ma'am, you will be sharing the screen.
So, can you start from the first slide?
नहीं उनको शेयर करना है जो प्रेजेंटर को
अभी यहाँ से शेयर किया
Yes, yes.
For some reason, Ankita's name is in much bigger font than the other. क्यों अंकिता ऐसा क्यों?
Sir, the organizing team should know. Are my slides visible?
Yes.
Yeah.
Yes. Make it slideshow.
Is it visible?
Yes,
It is visible, but can you do it on a slideshow?
It's not in the slideshow. Okay.
Not yet.
Is it okay now?
Yeah, it is fine. Please carry on. Thank you.
Yeah. Okay. Good morning, distinguished faculty members and dear colleagues. First, I would like to thank mentor Dr. Harshal Salve sir and my team members who have given their critical inputs for an online presentation. So the topic which we are given to group 2 was planning physical activity behavior change in a setting approach. So these were the key steps where we have to present our group work, which included to identification of various settings with one intervention, identification of stakeholders, list out the components of behavior change intervention for promotion of physical activity, make implementation strategy, list out the challenges for implementation, and develop a framework for monitoring and evaluation. So based on the discussions, we identified different settings where physical activity can be promoted. And we identified family, school, college, healthcare delivery center or hospital, medical college, community setting, which includes Panchayati Raj institutions, ICDS organization, village health sanitation and nutrition committee, residential societies, and workplace. But we finalized the setting which can have an overlap between the university and the workplace, and that is medical institutions. So as we all know, the rationale for promotion of physical activity, but just to reinforce the context, as we all know, 1 in 4 adults are insufficiently physically active, and most of us who are present online and offline would agree insufficiently after people have a 20 to 30% increased risk of death. And why we finalize this setting is creation of healthier workforce leads to increased productivity, reduced sickness absence, and lower work disability related cost. So we tried to finalize the intervention promoting physical activity in medical institute, proactive me. The identified stakeholders and the medical institute will have different sections which may have a target group, trainers and facilitators. In the target group, there will be faculty consultants, nursing officers and nursing staff, elite healthcare professionals, which may include the lab technician, administrative staff, the clerical staff, elite staff, which include security guard, hospital and sanitary attendants, and most important, who are the lamp bearers of this physical activity in future will include undergraduate and postgraduate medical, dental, and nursing student. Then the next stakeholder would include the trainers for different physical activity trainings and the facilitators, which are very important again, who will be the sponsors of this program that again have institute sponsorship, local gym, cycling stores, etc. And promoters can have the associations, alumni association, professional organizations like IAPSM, IMA, IPHA, and certain NGOs who are working in promotion of physical activity in the local settings. So we identified what will be the main components of our intervention. So we tried to categorize in two different domains, which may have structural intervention and information intervention. So structural interventions we derived were identifying a dedicated space for opening a gymnasium, setting up the gymnasium, procuring cycles and cycle stands, shaded footpaths for walking, and formulation of a, you can say, wellness committee for promotion of the physical activity intervention. The informational interventions may include sensitization and awareness generation among stakeholders, maintaining a sports calendar, an annual sports calendar, use of a social media platforms or different groups for promotion of activities. So this is a broad outline how we are going to implement our plan. So as all the implementation, this will also include some of the principles of the implementation research. We will start from the baseline assessment. The baseline assessment will include the infrastructure, human resource, key stakeholders, the preferences of the stakeholders for different training which they want to continue, and the logistics. The preparation will focus on arrangement of funds, recruitment of human resource, equipment procurement, physical development of a comprehensive and individualized physical activity package, and setting up monitoring mechanism. The third domain would include the deployment of the package, which will have again a domain of training, scheduling of the activities, and continuous feedback from the stakeholders, tracking of the indicators, and most important for promotion, for increasing the compliance to physical activity is the rewards. Rewards for all the stakeholders who are engaged and enrolled in the physical activity intervention. The last would be outcome assessment to assess the feasibility, sustainability, and whether we can scale up in other institution settings. So we will analyze indicators, there will be feasibility assessment, and we will identify the scope. So just to detail out these domains, as we have already listed. So I'll just take you through again. The baseline assessment is identification of the available infrastructure, because most of the new institutes, they do not have a dedicated space. Students, they have, most of them have playgrounds, but there is no dedicated space for the gym or the physical activity promotion, especially for the faculty members and the elite workforce. The next step becomes very important, is to identify the stakeholders and their representatives who are going to be very critical for promotion of this initiative and for sustainability of this initiative. And that mainly includes the representation for the student union, from the faculty union, and more importantly, the administration, the DDAs, the directors, and the dean. So if they are representative, if these representatives are involved in the committee, so they can be the advocates who can promote our package. And next is identification of the preferences, because as per the stakeholders are of different age group, they may have different comorbidities, so we have to identify what are the preferences. Some of them would enjoy regular going to gym. Some of them may prefer to have running event, maybe weekly or fortnightly. Some of them may have preference for cycling, and some of them may also have yoga or aerobic exercise preference. So accordingly, we can have separate groups, but first we have to identify what is their preference. Then we have to, based on these, we have to identify our logistics in terms of manpower in terms of trained manpower who can train in different physical activities like gym trainer, yoga trainer, etc., and a lead staff who can have maintenance of the gym equipment and definitely keeping of the records. So a dedicated staff for keeping all the records of this continuous activity. Materials would include all the possible equipment for different for different activities and a dedicated fund. So I've covered the logistic arrangement, and then coming to the development of physical activity. So we just tried to highlight it. What are the key contents of this module? So first is to we have to set the rationale of different activities. What will be the eligibility of doing these activities? What would be the do's and don'ts? What are the possible injuries one can expect? And what are the adequate postures for, suppose if someone is joining gym or someone is doing yoga, so we often miss that and we hurt ourselves. Then it will also have an component of self-assessment, and so there will be an interdisciplinary approach also. So we will try to integrate with dietetics, and also there will be an importance of sleep and better hydration. So none of the intervention is complete if we do not have any methods of objectively, there is an objective assessment built in that intervention. So very important step is to finalize the indicators, which will have input, process, output, and outcome indicators, the sources of indicators, how to assess them, what should be the frequency of reporting of those indicators, and the feedback of enrolled participants. Coming to the deployment, so once we have all this thing in place, and there will be some of the concurrent activities which will be continuous. So we have to set up the gym, we have to place cycle stands, we have to procure cycles. Then sensitization and awareness activities should be a continuous offline and online process. And then we have to maintain, we will be deploying the activities month-wise, week-wise, or fortnightly, depending on the consensus formed with the stakeholders. And the last is tracking of indicators. So these are the pictures we can, you can visualize that there will be a workplace wellness council. We can have a dedicated day, which can be a bike day to work day. And sensitization, one of the key focus is how much activity do I need? So just simply taking a walk for 5 minutes, 10 minutes is not enough. Again, this will be different for different stakeholders based on their age, based on their current activity levels, and based on their comorbidity status. So the baseline assessment, what we will be assessing them is physical. That will include the measurements of weight, BMI, waist circumference, hip circumference, body fat percentage. And one more important thing is to assess functional fitness like strength. So we can ask them at the baseline, suppose how many squats one can do, flexibility, the reach exercise, endurance. We can ask them about their track records of running, balance is yogic pose. Biochemical assessment will have like, it's blood pressure measurement, random blood sugar, etc. Psychiatric and psychological is that can be a self-reported informal discussion, how they are feeling at the baseline, or we can use some validated tool. But that will not be a priority in the assessment, and the records of the existing comorbidities. The important thing is we can have individualized goals of different stakeholders. Then there will be a continuous use of social media for tracking and training, and then they can see their own personalized progress. And at the we have different time points where we can track, we can assess, and we can reassess them whether we need to upgrade the package or the training time for them. So this is the tentative timeline which we have prepared based on the key strategies. So this is spread over a period of 2 years. So I would just take like, this is a month-wise Gantt chart. So we are planning to have a baseline assessment over a period of 3 to 4 months, and logistic arrangement would be a continuous activity. So by 8th or 9th month, we are trying to complete the recruitment and the procurement of equipment and manpower. The package will be an activity of around 3 months. So by the end of 10th month, we will develop our package. Then finalizing and developing the monitoring mechanism. Again, some of the components will be a continuous activity. So it will be a period of 3 months where we'll be finalizing the modules, the indicators, what will be the tools of the assessment, then the deployment. So by 11th month, we are planning to deploy this intervention, and sensitization and awareness activities will be a continuous process. Sports activities will be a continuous process after the deployment of the intervention, and monitoring mechanism will again be a continuous process. So the identified challenges, which we thought the availability of a space can be a challenge, motivating stakeholders and their representatives, procurement of fund. Whenever we talk, although we say we are aware about the statistics, but still this is a neglected domain to promote physical activity. But it definitely, we should say, it should start from the family, schools, but again we have an opportunity at the medical institutes where we can set this health culture and promote the physical activity. Availability of a trained personnel, housekeeping and record keeping, logistics arrangement, maintenance of the equipment can be a challenge, and developing a comprehensive physical activity package, which is age, gender, and adjusting the comorbidities. The regular monitoring of the physical activity. Here we mean like if there are different groups, so we have to, that will be a bit challenging how we are going to track everyone's progress. Although most of us wear smartwatches or have mobile applications, so there can be a digital tracking of these activities. But some of them like cycling and yoga, so that we have to consider while we develop this package and monitoring mechanism. And of course, in medical institutes, we all know there is always a delay in procurement and recruitment, so that can be a challenge. Now, developing a framework for monitoring and evaluation. So this is a framework which we have prepared. So the input indicators here will be development of the proposal, setting up of gym and cycle stands, recruitment of manpower, assessment of the baseline parameters, proportion of the participants who are enrolled, and detail the total fund collected. The source of these data can be minutes of the meeting records, records of all these parameters, procurement record, site visits, where we have identified that cycle stand, parking stands, or the gym sites, stock registers, and hospital database of staff and students, just to see what is the denominator, what is the total staff actually, and what is the staff which is getting enrolled in this intervention. So this will be the baseline reporting. Mode of assessment for most of the indicators will be both subjective and objective. Tool of assessment can be checklist, developing a questionnaire, medical records, informal discussions, and record review. Coming to the process indicator will have the training sessions for exercise, yoga, cycling.
I think you have a plan in position we can see, so we don't have to go through all of them. Can you go to the next slide?
So this is the last slide.
It's enough for us to see that you have a plan.
Yeah.
So any comments, buddy? Any comments from the group? Quick. We don't want to delay your lunch. Any quick comments from the audience?
Very nice presentation, team 2. For physical activity, my humble submission is nobody wants the physical involvement in physical activity. First of all, we should have the persons who want to do the physical activity so that they can encourage the others who are not want or they are not doing the physical activity. But because the sustainability of physical activity is very much problem. Thank you.
Okay, thank you, Dr. Bari.
Thank you. Yeah, Ankita and group 2, yeah, this is a very elaborate plan that you have made.
I think you've really taken a lot of time to plan out everything in detail. That I should really congratulate all of you. I think all of you have really worked hard because and totally online. Your group was online, so getting everybody on board also would have been quite challenging. The only thing which I observed is that you have a very diverse target group. So the activities that you're planning may not be applicable for all of them. So I'm thinking just at least narrow down your target group, either the students or the employees or the faculty. That itself will be quite challenging to be able to do these activities in even in one group. So I think if you're really planning to make aims Bhatinda like that, Ankita, I think you should narrow down it for a start to only one target group. Maybe students, that will be probably the easier one. They'll be more motivated, and then we could also think about using peer groups. I mean that as a means of motivation for each other, as Dr. Sanjay said just now, that we need to find out people who are already motivated and then again motivate others. I think that is going to also help. It will help in ensuring the continuity, because many people start doing a lot of things, but then it just fizzles out. That continuity and motivation doesn't stay. So that is one challenge with these physical activity programs. So yeah, and one more thing is we could also think of having institutionalized slots or timings for physical activity within the working hours, because many people we're talking about working people in the hospital or or students in the college. So if we can have that sort of a mechanism by which we have a compulsory break for physical activity, so that will also help. Then people will be able to do it. Otherwise, nobody will really find out extra time beyond the working hours. So yeah, that's all from my side. Thanks, Ankita, and all the group too. Well done, Arshal. Thank you. Yeah.
Request everyone to just switch on the videos who are in the group so that you can have a screenshot for as a picture.
Online participants, kindly switch on the video.
Okay. So I think yes, it was very nice, very elaborate. I really liked the title of the presentation with all acronyms in place. Workplace-based interventions are important for changing sedentary lifestyle, no doubt about that. So this is very much needed. One of just passing sharing of an experience is one of the faculty groups. This was being voiced that whether these gyms are going to have bathing spaces. When the infrastructure is being set up, it's also important, like people
Yes.
not only stay at campus, they come from outside also. And during those 8 hours, if they want to utilize, gymming spaces or for physical activity, we need to have these also in place because they are well utilized. So just keep that in mind. Also,
Yes, sir. We thought there will be a three-room gym. So one will be dedicated room, and there will be a changing room and a washroom. And again, the preference, because some of the female faculty may not feel.
Map of how they must have prepared whole map, designed the whole gym.
Okay, thank you. Yeah.
Sir, actually, I'm working on this agenda since 2 years for setting children park and for creating faculty group, but nothing is materializing.
Okay, good. Yeah. So just for both Ankita and Harshal are big on physical activity and runners. I walk, he runs. Similarly, Ankita also, she is our student, so I know her. She's also big into physical activity. So that is why that group is very motivated to promote physical activity. But only one thing is that most of these are in campuses. Campuses, family members are also there. So why did you not include children of faculty members?
Sir, I think it should be a phased approach. As ma'am said, we should target one group
stop them,
and
no?
then family.
If you have a cycle, they want to go, you cannot say you are not in my target, you cannot use a cycle. So it has
The
to
problem is the logistics. That then gym has to be functional 24/7. Who will be? So we thought that will be a second phase.
डॉक्टरों को भी रात शाम को ही करने को मिलता है तो 24/7 की जरूरत नहीं है but ultimately just so they are also important. Sometimes children might push their parents to do physical activity rather than the other. And I think you talked about it later. Faculty association, nursing associations, they are, I think, good, most important stakeholders. Finally, I think also, ये तो medical college है. ministries of health also have to think, because there are people from ministries of health. And Manoj told me that he used to do a lot of physical activity before. Once he joins the HMI, uska physical activity khatam ho gaya. That is true for Reddy Saab also. So why not also promote physical activity within offices in ministries of health? उसमें एक जिम लगा सकते हैं. निर्माण भवन में लगाया है उन्होंने, but
Sir, we should have a reward every month. Fitter faculty, fitter employee.
We got in our office and WHO country office, you know, we have every
what can be done to put you inside that gym? Gym is there, you are there, but you are not inside the gym.
What can be done? What can be done from our side is that we need to be stress free from our project first.
वो तो रहेगा, मेरे वर्क एंड स्ट्रेस तो
LCDs तो नहीं बंद होता है, so our stress is not.
स्ट्रेस इज बाय डेफिनेशन जो हम लेते हैं, देता नहीं है कोई स्ट्रेस. आप लोगे तो स्ट्रेस है, नहीं लोगे तो स्ट्रेस नहीं है ना, तो मतलब स्ट्रेस.
Yes.
हाँ.
Sir, just 10 days before we operationalize a gym and table tennis in our Directorate of Public Health. For all directorates, 9 directorates are there. We operationalize a gym and a table tennis court inside the directorate for our office staffs.
Health ministry नहीं करेंगे तो बाकी ministry क्यों करेंगे? We have to take the lead, right?
Sir.
I say we have to practice, self practice before preach. Ministry health practices before it preaches other ministries.
Open gyms, you know, the concept of
I
open
have
gyms.
only one concern. We should not make physical activity synonym with gym. Physical activity is a part of life. Take a stair, walk. Gym is not essential to promote physical activity. So I don't want to send a message that physical activity में एक gym लगाओ, नहीं होना चाहिए. Yeah.
On Ministry of Defense, what they do every Wednesday, they like all officers, including all senior admirals, generals, and everybody, they park their car or whatever at metro station, that race course metro station. वहां से वो लोग साइकिल लेके वो लोग उससे जाते हैं ऑफिस. And on Wednesday also it is like orders from headquarter कि Wednesday को कोई भी lift नहीं चलेगी, whether it's on 4th floor or 5th floor. So it's a good initiative.
That's what I'm saying.
Yes.
If you want to encourage physical activity, you will find ways to do it. Yes. So just you have to exert yourself, find ways to promote physical activity in office, wherever. Thank you. We can now go to the next group.
Is it audible? Very good morning to one and all. Myself, Dr. Very good morning to one and all. Myself, Dr. Vinodini from Banaras Hindu University. Here I am representing Group 3. The title which was given for group activity, assessing and implementing people-centered NCD services in primary healthcare facility. Why we are bothering about NCD care services especially? Because we have seen for the past 4 days, the mortality is more with NCD care services, even in globally as well as in developing India also. So the mortality rate is 70% at global level and 77.
You can skip this.
Okay.
You can go to just because we are otherwise we'll.
So this is a problem statement just to give you the clarification about the prevalence of hypertension among adults aged 18 to 69 years and the prevalence of diabetes among adults aged 18 to 69 years. The study was done in 2016
17 National NCD Monitoring Survey. Here, 29.2% of the people are aware of the disease in hypertension, and 16% of the people they got treatment, and 12.3% of the people they are actually under control. Likewise, in diabetes also 47.6% of the people are aware of their blood glucose level, and 38.5% of the people were on treatment, and 12.3% of the people they are under control. So there is gap between awareness, treatment, and adherence. Why there is a gap? There is a hurdle in all the levels: diagnosis level, treatment level, and as well as in continuity of care level. In diagnosis level, the screening is not done, and inaccurate measurement is also there. In treatment wise, there is no simplified protocol in system level also, and there is no dissemination, and there is no utilization in healthcare facility level, and there is drug shortages, and in private sectors also there is no proper dissemination of simplified protocol, and there is no data monitoring for all the NCD services in private sector as well as. And there is more patient flow, patient workload is also more, and the consultation time is also less. So that people, they are not getting a good enough consultation time from the doctors. That is also one of the reason. And in continuity of care, there is no reminders, no recall systems, and there is no perfect information system to monitor all these things. And there is a low adherence. Because of all these things, there is hurdle in continuity of the care level. So since 2000, there is so many efforts from World Health Assembly side as well as Ministry of Health and Family Welfare side to complete all these NCD related issues, but still there is no improvement. Why? Because unless otherwise people are not involved in taking part in the NCD services, and whatever services we are providing, if it is not in the people's need, definitely that service will not work. So that's where people-centered care started. What is people-centered care?
Skip again. They have already told what is people-centered care.
Sure, sir.
We can even skip this. Just come to your.
Okay.
You can skip all this.
Okay, sir.
This also.
In our group.
What was your group's this thing on how to implement, right?
Yes, sir. Assessing and implementing the primary health care.
So just come to that. This
Sure,
one we
sir.
can skip. Unless यही है तुम्हारा presentation, वो मुझे नहीं पता. How many slides do you have?
Totally 18.
Okay. Okay. So we can go from here.
The challenges are actually we noticed from all over, depends upon the group members, and in challenges, poor health seeking behavior of the community is the one reason. Definitely we would have heard this one sentence from our family or neighborhood people about if we ask them to go for screening, first of all, they will say, I don't have any issues, I am perfect. And if at all they are diagnosed with all these issues, they will be this is very initial level, so I don't have any problem, so I can take care of it. So poor healthcare seeking behavior of the community and the bias towards tertiary care facilities in terms of seeking NCD care, and the apprehension regarding A&M skills in NCD care. These are all the main challenges at community level. And challenges noted in primary healthcare centers are lack of prioritization of A&M towards NCD care. Because long years, people are A&M services mainly towards the RM and CH. So they are well trained in taking care of the delivery services and other ANC, PNC services. They are not aware of this NCD services. So they are not interested in taking part. So there is lack of prioritization of A&M towards NCD care. And pandemic and other external factors, because of those pandemics and facilities were shut down, And that time, people were rushed to either they were rushing to tertiary care centers or they were not interested in going anywhere else. And inadequate manpower source, especially lab technicians and nurses. And in quality changes, a lack of proper training and lack of utilization of robust protocols in healthcare centers. And in system level, challenges noted are program monitoring and management are not up to the expected standards, and lack of timely dissemination of protocols that have been made already, and poor supply chain as well as inadequate and irregular drugs and testing. There is no multi-sectoral coordination, and budget allocation is also low, and utilization is faulty utilization. And suggested level-wise solutions. And in community level, the resources, solutions, empowering and educating the community through the frontline workers. It shouldn't be the frontline workers, and we can add school teachers and motivated youth and beneficiaries. They can also take part in these things. And the indicators are we can check through CBAC forms that should be filled. It is a proxy measures of ASHA for visiting home as well as household visits. We can analyze this through disseminating IEC leaflets as well as village health, nutrition and sanitation committee meeting records, wherein there is a documentation have been made. And in facility level, the solutions, community champions, leaders of the communities, they can be used as a role models to talk to the community in approaching the PHCs for NCD care, to get the trust of the people. And here medical officers, he will identify such champions and he will arrange for this kind of interaction. And the indicator for this, we can document the event as well as after that through improved OPD attendance as well as hypertension and diabetes incidence rate in area. Through that we can monitor these things. And the next solution is community health organizations to be identified and roped in for NCD champions. Roped for NCD champions, NCD campaigns. So here, medical officer identifies the community health organizations and takes a permission and arranges for such events on special days. And that activities should be a community friendly activity. So here the key indicators are documents and records of these activities can be helpful, and the attendance registers, that attendance may be for stratified ages. Some of the people are in vulnerability group. So based on the group also, we can make the registers. And feedback mechanisms encouraged from the community users. And the next solution is outreach services to the community sessions by the medical officers. So here, mobility support provided by the facility may require system support for vehicles and carrying requisite testings and logistics. So here the indicators are a frequency of outreach sessions. We can take it, and maintaining the beneficiaries into routine system pools. The next solution is weekly meetings should be held at the facility level. Here we can utilize the available workforce, like whoever is working in that facility, we can conduct meeting for all those people. And the indicators are number of meetings in a year. We can take it out. Minutes of the meetings can be recorded and actions taken based on the minutes. The next solution is task sharing and multitasking. So here, available health workforce will be used as a resources. So the indicators are a maintenance of delegation log and as well as a primary provider and backups. The next solution is cohort monitoring. So after maintaining all these things, we can monitor the disease in a longitudinal basis. So here the resources will be available workforce and better documentation can be made, that is for a disease specific, and indicators are a patient dropout rate and disease control rate can be used. Then supervision, here medical officer or other senior functionaries can be used. Indicators are a checklist, standard protocols of the NCDs can be made, and supportive and corrective actions can be taken before the next meeting. In system level, the solution is timely filling of vacant positions. So the resources are employ MBBS doctors at the primary level and incentivize them and integrate with Ayush systems. So the key indicators are vacant positions. And the next solution at system level is drug forecasting, first in first out approach, procurement, and develop a robust supply chain to avoid delay or stockouts. Here, identification of best logistic partner to deliver the drugs at the facilities within the turnaround time, and financing and timely payment, procurement from state offices also. Here, the indicators are utilization registers, intending registers, and procurement registers. The next solution at system level is periodical monitoring and evaluation with inbuilt feedback mechanisms. So the resources are state and district NCD cell team members, and the indicators are frequency of visit. For a state NCD cell team, they can visit quarterly, and a district NCD cell team members, they can visit monthly. And the documentation of the visits can be made, checklist filled in the visit. This is practices, now it's moving. In Gujarat, regular weekly afternoon meetings every Saturday since 20 years. And in Telangana, dedicated NCD staff nurse in primary healthcare centers since 2018. And in Kerala, peer support groups for patients to learn from each other's experiences. In Telangana, used local leaders as a role models to access primary healthcare, and also identified enthusiastic medical officers who are succeeding in their fields and appointed them as district program officers. And in Tamil Nadu, mobile medical unit is one of the practices. So reach all, treat the needy, and miss none. Thank you.
Any comments from the audience? Including online participants, if they have any comments.
Any comment from online participants?
Thank you. I think this is something which probably many of you, this concept of person-centered care, maybe you would have heard for the first time, or maybe not. It's not a very, it's not something that we often talk about. But if you see that it is actually nothing new, it is not a new concept. If we look at the program, say TB program or HIV, they've always used this patient-centered care, but in a different manner. Like we used to say that, especially in HIV, the chronic care model is nothing but this same. It's just being packaged in a different way, and it's the new terminology has been given. Like, so it is really nothing new. It's not that we have a different system of delivering the healthcare services. If you see whatever the activities or the interventions that she has listed, they are the things which are being done. There's nothing new in that, but the only thing is that we have to provide good quality services to the patients and keeping the patient's interest in mind, not like our own interest first. I mean, not only from the health system perspective, but there is one more issue that probably we have to really, she has not mentioned this, in people-centered care or patient-centered care that we talk about. We also have to empower the patients, for self-management, because this is more relevant for chronic diseases. Unless the patients themselves are empowered to look after themselves, or they should be empowered to take care of their own health. They should be able to do the self-monitoring of blood sugar, their blood pressure, how to, or if not themselves, but at least the family or the immediate family or the caregivers should be. So that is also one important component of, this patient-centered care. But otherwise, it's nothing. You don't go with the idea that this is something new that we have introduced in this workshop, but it's actually delivering good quality services to the patients and keeping the patient's interest in mind. Okay, so yeah, that's my only comment on this. And congratulations to the group. I think you've really done a lot of work. It's like the whole NCD program encompassed into this presentation. Thank you.
Yeah, thanks to the group. So just one observation and comment is that in the basket of all suggestions, when we make, we also have to do a little bit of prioritization, and it's very important to think what can be done, on an immediate, which is there in the hands of managers. So, for example, if we want to, there were some health system issues being brought out, vacancy of positions. Sometimes it's not very easy to get these positions filled, and it takes really a very long time. So in the people centric care, depending upon the constraints that are there in the environment, we still have to go ahead with the resources that are available, keeping the interest of communities and the patients and their needs interest being met, creating local champions and advocates for action.
It was a good presentation, as said by Varim. It was a new concept, as I will say, the old wine in new bottle in a sense. But we should be sort of wary of situation, because every time NCD is a program where everything is adding up since 2010, right? And it is increasing the burden of our peripheral workers, be it ASHA or CHO now at the healthcare. The program people might be aware of it, the duplicate reportings and all these things is happening. So we have to develop our interventions, the new initiatives under the ambit of the existing program without adding too much into the reporting. I see a lot of registers and reporting coming up. So we should be taking the stock of it. So we should consider not only last person we have to reach, but also the last person who's going to deliver the service. So that should be our center of focus. But it's a good concept, and some small things, as said, a phase-wise manner can be taken out for implementation. Thank you.
Thank you. Again, good presentation. Maybe based on some more theory, but as we are just learning these concepts. But again, a request to all state program officers to see how you can, even in small ways, can make your systems more patient friendly and patient centered. You may not be able to do everything, but start small and gradually build on it to improve your. And we saw that many things can be done from the IHMI experience. Many of these things that we are asking people to do have already been done. They are not very new interventions. They've been proven to be feasible. It just needs some commitment at the administration level, whether it is MOPHC or a district. With some commitment, a lot of changes can happen. Thank you. Okay.
Group. Is it an uneven distribution or what?
Yeah.
Thank you so
Thank
much.
you. Group 4.
Am I audible?
since this is 12:30. I can say good afternoon. Good afternoon, everyone. I feel very happy and privileged to be like sharing the stage with the senior faculty and be in front of you all. I'm representing Group 4. Our Group 4 moderator is Berry ma'am, and we have group members from Gujarat, Delhi, Haryana, senior nodal officers and program manager from Hriday, and rest are the junior residents. Our topic is Health Management Information System, a data-based monitoring of non-communicable disease program. Here I am presenting you. My name is Dr. Nikita. I am from Banaras Hindu University, junior resident in Community Medicine Department. So objectives of my presentation are like I'll be outlining the data flow and challenge. We'll be seeing the challenges facing in the routine HMIS data and quality of reporting, and we'll be seeing the action points which we have made, and then finalizing the policy brief. So what is Health Management Information System? This is information system specially designed to assist in the management and planning of health programs as supposed to deliver care. This is a government-to-government web-based monitoring information system. The analytical reports generated through HMIS also provides gap analysis and evidence-based scores. So basically this works as a very big data set where we can utilize the health information and like we can monitor the programs, we can analyze the situation, like we can do situational analysis and many things. Since like India is getting digitalized, like every program are being digitalized, so these we'll be getting major databases. So we'll be needing portals and databases management system to carry on this data. So my first objective is I'll be showing the outflow of data from subcenter level to national level. As we all know, non-communicable disease program starts at the grassroots level by ASHA. She'll be doing population-based screening. She'll be completing the CBAC form and creating individual health cards and maintain village register and family folder. These are the family folders which are filled by ASHA at the village level. This is pro forma for screening, which is filled by ANM. This is the flow of data of information. This is exclusively for NPCDCS program. At the subcenter level, form 1 is filled by ANM, and then it is forwarded to PHC, where medical officer will be scrutinizing it, and he will be filling form 2, and then this will be carried forward to CHC, where medical officer will be filling 3B form. And in the other side, district NCD clinic, a medical officer will be filling form 4, and CHC NCD clinic medical officer will be filling 3A form. These two will be compiled as 5A form, and from other side 3B forms will be compiled for 5B. So 5A and 5B from the district will be going to district NCD cell, and then state NCD cell will be filling form 6, and then it will be provided to national cell. And the last date of submission at each level will be seen. So at subcenter level, it is like ANM should be forwarding the data at by last day of every month. At PHC level, it is 5th of every month, and at CHC level, 7th of every month data should be forwarded. And then at district level NCD cell, at least by 10th of every month data should be forwarded, and then state NCD cell by 15th of every month. This is a sample form of form 6 at state level. Now the second objective will be seeing the challenges faced by like online health information management system. Basically at the like grassroots level, at ASHA level, forms are often incomplete, so credibility is questionable and often fail to complete on time. ASHAs visibly overburdened by the number of tasks they are expected to perform. Inadequate number of training inadequate number of trained floor workers to conduct population level screening, health promotion and prevention activities as envisaged by National NCD Cell Program. Basically there's a lack of human resources. Difficulties in defining the target population, that is like in and out migrants are, they may create confusion. And basically at present reporting is done manually, so it affects the quality of data and it is prone to many errors and timely submission is difficult. And around 30 to 40% of sub-centers do not send data at all. And some more challenges: number based entry, that is like example, number of number of diabetes cases, like they just have to note the number, so there may be chances of data hampering, manipulation. And data entry is linked with incentives, which will be creating which will be a chance for manipulation, like they can show that they are working more and they can show more numbers so they can get incentives. And when they don't get incentive, they may not work also. So this is one of the challenge. And analysis of data and further monitoring and evaluation, all difficult in a manual reporting system. And non-availability of data, major reasons that programs are not effectively monitored. And lack of quality assurance procedures. Some more challenges: reporting is only from government setup, so private sector data is not reported, so there is gross underestimation of actual burden. Existing health system is fragmented, like suppose for example Gujarat has 18 portals for different health programs. They have to enter data in different health portals, which will be creating overburden and confusion to the workers also. And like with so much of data, like nobody will be seeing at the data there. Some of the program, like don't take it personally, some of the program managers like won't be knowing what to do with the data. Yeah. And there's a chance of same data sent by different modes and different reports. So it increases work burden and chances of duplication is also more. NCD management being multi-sectoral will require collection of information beyond health sector. So these are, I'll be repeating again the like overall challenges and gaps. Yes. So we have seen the challenges and gaps. Now let me try to show you some solutions. Like we can, like since now manual reporting is going on, we can implement online reporting overall. And proper monitoring should be there. Authentication of data is definitely needed. NCD program should have a single reporting format. Like we have seen, like there are many portals and many portals will be having different formats. Nationwide implementation of Clinical Establishment Act and Public Health Act. By this way, we can involve the private health sectors also. The other objectives are like now we'll be seeing the data available from the Gujarat. We'll be analyzing 2018, 19 and 2020 data. The data is collected from Form 6 of Gujarat. Number of district NCD cells are 33. So if you see the year-wise distribution of total number of persons attended by NCD clinics, in 2019 there is a like appreciable number of coverage, we can say. Like number of screened people have increased from 2018 to 19, and then maybe due to COVID, it has been decreased in 2020. And because coverage was increased and we could find the number of diabetes cases and hypertension cases And both here it shows that burden of hypertension and diabetes combined, like comorbidity, multimorbidities are on rise. Same with the cancer screening, it was increased. These are some of the data, like individual disease distribution. Almost like hypertension and diabetes are taking major part, and also combined both diabetes and hypertension, and almost disease distribution is almost equal. Also in 2019, the trend continues. 2020 also, like hypertension and diabetes, we know that these are chronic diseases, so trend is continuing. And but we see that coverage was increased, but treatment rates are decreased. Maybe because coverage was increased, but we are unable to provide the proper treatment. There may be lack of drug supply chain. But we have managed to provide the treatment for even during pandemic. This is appreciable. Now we'll be seeing the action plans. Like through online data system, we can identify what are the missing cases. Like data will be available all the time. So whenever we want, we can go through it. And as I have said already, there are many portals which will create confusion. So we can integrate the health portals to make it uniform. And we can strengthen surveillance and strengthen logistic supply and ensure timely surveillance of reports. All these challenges and solutions are made into policy briefs. This is a policy brief. Like with India being digitalized, we can expect more. Like now we are in initial situation of transformation from manual to online, so we will be finding many difficulties and challenges. But in future, we definitely will get out of this, and we will be integrating all the health systems into uniform form. Thank you.
Any comments from the group?
Yes, ma'am.
Yeah, it was a nice presentation, and it was, I mean, a proper mention about the data hampering. Like, I would like to share my experience how this data hampering affected my thesis personally. So, I wanted to do a hospital-based study on assessment of adherence to antihypertensive medication and its predictors among the rural population of Varanasi. So when I went to the hospital, they had a very good data showing 500 people, 600 people screened every month, and even the block program manager gave me the hard copy. So even I saw its register, I saw the number, just there were 600 people entered. So I was very much excited, but once I analyzed what is actually written, only the name and the area is written, and the phone number was not written. And I spent time in the CHC or PHC, but I couldn't get the footfall of hypertensive patients. So I was forced to go into the field and converted my study from hospital based to community based. Now I'll share my experience furthermore. Like when I searched for the patients, so far I have covered 240 hypertensive patients across 8 villages. Across 50,000 population, that is only 50% of my sample size. So out of those 250 patients, 240 patients are getting treated by private practitioners, and out of those 240, most of them are getting treated by the quacks. So now I have converted my community-based I've been study to observational study into mixed methodology study, where I have to integrate the information from both the medical officer and stakeholders with the patient. So this is how the data hampering affected my thesis, and it's very. And also you mentioned the solution for the offline data hampering is online. But I feel that it all depends on the mindset of the dedicated human capital. If you want to enter bad data or if you want to hamper the data online, it is much possible. So I don't see that as a solution. So
Cross evaluation, cross checking has to be there. We have mentioned.
Okay,
thank you.
So you learned real public health. That's very nice.
So it's not hampered, it's modified.
It's a learning opportunity. Yeah.
So this is also in a way a learning opportunity. So when we were looking at UPHMIS and how it's being integrated, the HMIS is being integrated, and there are again a lot of structural and manpower issues. You don't have data entry operators, you don't have internet, you don't have computers. They are not trained in how to utilize these facilities. So I think even taking all of that into account is so important as well, because if your data is say available on paper but you're unable to input it, that's also a very big setback.
She wants to say
data element that they're entering. They're just seeing numbers and entering, So it's not that they're fudging, but actually their understanding is lacking. So that is very important. And secondly, for the HMIS or the CPHC app, a line list is not available. So how many follow-ups? Follow-ups are so many happening. Like every day they're writing follow-ups. Maybe one patient is coming in a month 3 times. He's counted as three. But actually it's just one patient coming. So because of the absence of a line list, which is very important, like they said, not required, a hypertensive registry is not required. It should be there, but it should be in the CPHC app that we can download the line list and get it. So very important having line listing.
Yes. I recently joined as a SPO, and I seen that the data which is being compiled at my center. In 2019, the footfall was 4 lakh something state-wise. And in 2020 and 21, when the COVID pandemic is all over in Delhi, I seen that 6 lakhs in 20 and 7 lakhs something in 21. When I recalculated, I have seen that it was only 60 or 70,000, because the Google sheet which have been prepared, the cumulative figure have been added in the main part. So that's why the figure gone up. It is 6 lakh in 6 lakh and 7 lakh. Actually, it was 60,000 and 70,000.
Okay, any quick comments from this part of?
The only thing which the important thing is that there should be a unique ID that will at least avoid all this duplication and double counting of the cases. Unless we have a unique ID for every patient, I think this problem will never be solved. So yeah, otherwise,
Most of the places when we visited for our COVID-related work also, most of the program officers and the DPM, they are more like in coverage, sort of 80%, 90%, because they have been asked to report like that, because they gives their achievement in the form of coverage. But we should be worried because we work in epidemiology. So denominators are our key. We should thrive for it as line listing, unique ID. These are mechanisms to get our denominators right, so that we can count person individually, avoid duplication. So that is the key for most of the data. Thank you.
I just want to say that, the data is generated, but it's not utilized. And that's the sad part of the whole affairs. I mean, the data entry operator enters, but I mean, who makes use of it? I mean, where the feedback is given. And I mean, the simple indicators of, how many being missed for treatment initiation. I mean, all of these things require a discussion and orientation. I think the system has to gear to address these things. I mean, everybody knows there are challenges in HMIS, from manual to web, and plenty of apps and portals to enter where system is confused. I think the solutions are addressed. It will take long time. Unique IDs, the concept is coming in, reforms are there, but whatsoever is being generated also has to be put in use, and we need to gear towards that.
Thank you. Just to endorse what Sumit said, I think district program managers, state program managers have to learn to really utilize HMIS data and use it for program planning and monitoring. That's critical.
Parameters on TB, and TB has this mixture ID. So this data privacy is also coming up in a big way. Like we as researchers, we have this habit of assembling data, asking the state or the district. So now I think there will be riders of restricting people to have access to data. So that also I think we'll see in coming years, wherein I think if we are having everything entered online, like you said, the mobile numbers too much of identifiers. I could not access Nixture. Like they said, Nixture is only for the program managers. I needed the data. It was an ICMR project, but they did not give me access. So I think in the long run, because NCD has a little stigma attached to it, so I feel that accessing NCD data would not be as easy as HMIS. Because HMIS is a routine like maternal and child health and immunization. These are developmental, but NCD I think would have a little privacy to it. I think.
Very good point. As we move towards everything electronic, privacy would be important. Just remember that for program monitoring, we don't really require IDs. We are only looking at numbers. Just for individual care provision, we need details of the ID. Yeah, we have to be careful in the way that we are going to use IT. It has tremendous potential for loss of privacy. Thank you.
Thank you
so maybe you want to take a group photograph. Group photograph. Oh, sorry. Sumit.
Like a press conference.
Thank you. Thank you. Now we come to the last group. Group 5 on implementation research. Distribution बुला बुला के देना है कैसे देना I know.
Good afternoon, everyone. Good afternoon, everyone. I'm Dr. Lavanya, representing Group 5. So our topic was implementation research protocol and NCD prevention and control. So basically what an implementation research is, like there is a program that is already running, and then you try to find what are the implementation gaps in that and try to fill it with certain strategy. So that's what we have done here. This is our group and group members. So the topic we came up with was upscaling implementation of TOEFL guidelines in the schools of Eastern Uttar Pradesh. So the group activity process was like, first we came up with the topic, and then we did some literature search for evidence synthesis, and then we went ahead with framing the strategies for the interventions. Smokers don't grow old, they just die. So this is the synopsis of the presentation. So it will be an introduction and then the literature review or the evidence, how we got it, and the aims and objectives of what we are proposing. And then there is a methodology of how the proposal is going to be going. So the introduction part is, so cigarette. Okay, one thing I wanted to mention is school, we have taken the rationale behind this is because the addiction is more stronger among the school children. So taking action here is very important. And also I wanted to show this map because we can clearly see India, the brown color is very prominent from other parts of the world, which is that oral cancer, and 40% of the cancers are related to tobacco use. So the psychosocial determinants of tobacco consumption will be, there are certain predisposing factors like knowledge, beliefs, attitudes, and all that. And that accompanied with barriers such as lack of enabling environment, easy availability, peer pressure and all, is leading to tobacco consumption. But we can have certain facilitators like awareness through IEC, behavior change communication, motivation, stress management. And these facilitators can be used to address the barriers, and therein we can bring a tobacco control. This was a basic idea that we had before we saw all the literature. So then we went ahead with the current existing laws that are there, the CODPA, National Tobacco Control Program, TOEFI guidelines and all. So the guidelines is basically no inside the premises the tobacco should not be used by any of the staff members or the students or anybody. And then signage board should be available. Monitor should be there. Tobacco monitor should be there. The school should undertake tobacco control activities from time to time, and within 100 yards tobacco products should not be sold. These are the basic guidelines. So with this we did some literature review and we got this. So the evidence suggests that displaying of signage boards and selling of tobacco product within 100 yards is not implemented properly, that we can see from the evidence clearly here. So from these we got to know what are the enablers from all the literature search. What are the enablers that will help us to implement TOEFI? That will be like motivated teachers, training workshop for teachers, student involvement, organizational ownership, the drive should be there, extracurricular activities, social influence models. These will be the enablers for us to effectively implement the guidelines. So the barriers to it will be from individual level, school level, community level, and institutional level. Individual level will be like from the institution point of view, like school point of view, lack of support, lack of enabling environment, disinterested teachers, teachers also using tobacco, lack of awareness for the tobacco vendors, and school barriers will be like there is no supportive enabling environment. Community barriers will be the norms, and like for children it might be like even peers who saying like the smoking tobacco is very cool and all. And institutional level will be unavailability and lack of coordination with the tobacco advisor. So these will be the barriers and those will be the enablers. So with this we came up with the goals and what are the objectives we are proposing. So to ensure successful implementation and adherence to TOEFI guidelines, the objectives were like in one block in state of Uttar Pradesh, we wanted to explore the status of implementation of TOEFI guidelines along with enablers and barriers to successful implementation. Then formulate a intervention package to ensure enhanced implementation of these guidelines. So the tool that we used was Consolidated Framework for Implementation Research. So it basically is the intervention and the characteristics of the intervention, how it is going to influence in the inner setting and the outer setting, what are the processes that will be there, and is it adaptable with the current situation, not something new. It should be compatible with the current existing functions. So this is the CFIR that we came. So the inner setting will be lack of interaction with the state nodal officer, cultural norms about tobacco, demotivated students and teachers. So outer setting will be another environmental level, the tobacco control policy, lack of capacity building and all that. So there will be certain processes, level of engagement, who will be engaged, when will they be engaged and all. And then what are the characteristics of the interventions that we are proposing and how the characteristics of the individuals will be affected by that. So the methodology is we have taken one block in Eastern Uttar Pradesh, Gorakhpur district, and 8 clusters have been selected, and these 8 clusters we will test our intervention. So the stakeholders for this intervention will be in 2 forms, like inner circle and outer circle. So students, headmasters, principals, teachers, these all will be the stakeholders in the inner circle, and education department, tobacco control officer, chief medical officer, all will be in the outer circle. So we also did a stakeholder analysis. So this stakeholder analysis is like from 0 to 1, 0 to 5 and 0 to 5. The power and influence, who has the maximum power, who has the maximum influence. So in case of school children, if you take, teachers and parents will have high power and high influence. So these stakeholders are very important. We do this analysis to understand who are the stakeholders we should be actively involving in our implementation process. So if we take peers, NGOs, actors and all, the influence will be very high, though they don't have much power on them. And bureaucrats, program nodal officers, police officers will have high power, but their influence on the students will be very minimal. And ANMs, ASHAs, their role will be minimal. So we need to understand who all the stakeholders are, how they can be involved in this process. And we should also do a needs assessment of them, like how sir said. What are the needs? If I'm going to give this intervention and this person is going to be involved in implementing that intervention, is he okay with it? Will it be compatible? It will be feasible for him to do it. So all that will come in the stakeholders part. So next is we plan it to be a phased implementation process, and it will be in 3 phases. First is the formative phase, then is the pilot, then is the trial. So this is the roadmap of how it is going to go. First, it will be a baseline assessment. We'll go and assess all the schools, see with the TOEFL guidelines, are they adhering to it and what is the level of adherence to it, and we'll grade the schools accordingly. Then we will test and pilot test all these TOEFL guidelines and how it is there, and then identify which can be the intervention group, which can be the control group, and it will be stratified according good performing, bad performing, urban, rural, everywhere. And these intervention packages will be tested for feasibility. If it is okay, it is implementable and all that. And in the first initial phase for 6 months, it will be implemented and then evaluated. Following that, there will be a continuation phase for the next 24 months. So in the formative phase, the same thing I said, there will be a quantitative questionnaire, that will be a qualitative approach, and all the exploring the barriers and what are the good practices in certain schools, what are the bad practices, or why certain thing, one thing is working in a school and this is not working in another school, what is there here, what is not there here, and trying to fill all these gaps. So grading will be done, and then multi-stakeholder collaborations might be done, needed for implementing our strategies. And then the pilot testing, feasibility, if whatever we are trying is feasible. Next will be like dividing them into control and intervention arms, and it will be done as a stratified approach by public schools, private schools, and for equal representation of everybody. And then the intervention packages will comprise of, so according to the TOEFL guidelines, since the guidelines are there, but then there are implementation gaps. So we've come with certain interventions. One is, first, the school committee should be formed. It will be formed with the help of with a steering committee, and it will be chaired by the chief medical officer, chief education officer. So the school committee will be involved in certain roles and responsibilities like conducting awareness programs, capacity building, and then doing surveillance in the school premises, like if tobacco is being used by any of the students, if the signage boards are there. So this committee will be doing all this, and this display of signage boards and all, we can allocate a different fund. Usually there is an IEC fund. That fund can be more specified as a signage board fund. So it is more practical that they have to do it. It becomes a mandate, because IEC fund may be used for anything. So if you would definitely want signage boards to be there, then we can have a specified fund in that way. And then no selling of tobacco products within 100 yards of institutions, like awareness creation can be done, and then monitoring and surveillance, everything will be done. And the school committee will also be involved in monitoring and evaluating all this. And then certain tobacco control activities and awareness programs will be conducted. And NGOs can be involved, quitters can be, who successfully quit tobacco can be involved, and youth, their actors can be involved, social media influencers can be involved. This can be happening in 3 months period for like workshop, and parents can also be involved. All the stakeholders can be involved to create an influence among the students about get awareness and create an impact on them. So quit helplines is also an important thing, since earlier we saw from the global youth tobacco survey that around 11% of students are already smoking. So cessation counseling should be there. Though it's already existing, there are implementation gaps in there. So what we can do is, we can maybe appoint a school psychologist who will be able to manage the psychological mental health component of that, and also be a linkage for us to send them to the cessation counseling. So this can be done through the National Tobacco Control Program. A separate fund for an HR or existing HR can be done. It can be done through a needs assessment, like how would they like to do it, like weekly ones, or how it is practically possible, what is the action plan to do all that. So that is it. So the trial will be for the first 6 months, and then the continuation phase will be for the next 24 months. So end-line evaluation will be done with the input indicators, process indicators, and output indicators. The indicators will be formation of the monitoring group, the training, supervisory research. So if these are all done or not, then the process will be number of meeting conducts, fines imposed, what are the awareness activities they have conducted, if the minutes have been, the action from the minutes have been done. The output indicators such as signage has been placed, active tobacco monitors are there, no sale of tobacco product around 100 meters of the campus, and tip filling of tobacco performance, and all this. So qualitative feedback can also be gained,
like feedback from the teachers, like in-depth interviews, key informant interviews, success stories of upcoming challenges, and all can be explored in this area. And statistical analysis. Okay, that's all.
Any comments from the group here or online?
Yeah, that was a good presentation. So, ma'am, you mentioned about the involvement of actors in promoting this, but I feel actors are more interested in this Vimal Elachi, Kingfisher Soda, and Royal Stag music CDs. So they won't contradict their. I mean, nowadays actors are very clever, and I don't think they will be attracted to this, and they will contradict each other. So people are motivated to these things, but I think that is a real challenge. I don't
Yes,
know.
that is a real challenge. I agree that, but as we have narrowed it to only school tobacco-free school initiatives, we have narrowed it down. If you see for Kotpa, maybe then surrogate ads and ads related to frank ads for this can also be regulated. So when that regulation comes, their influence, positive influence on tobacco will be down. And these students are young students are always in the social media, and they're very much influenced by these actors. If we are able to bring them and them having a talk with them, will have a better influence in the, like even social media influencers, it's like a social marketing principles, like what is the place, who is doing it, so like that. So it will be, if we are able to do it, it will be very good.
Actually,
After, go ahead, then she can.
in continuation of Vimal Panilanji, Delhi government has given the notice to Ajay Devgan and Pierce Brosnan. And the coast, basically Vimal Ilaichi and Sompan, Dilbag Tobacco, they have filed the case in the district court, and the case is sub judice. And regarding the toffee guideline, basically what we have done, we have created a Google form, and through Department of Education, we have circulated to all the schools to fill the form, and they have done the self-evaluation, and now we are going to evaluate them and give the tobacco-free school certificate or accreditation. And one more challenge we are facing, sir, herbal hookah. Basically, herbal hookah do not have the tobacco. So that's why it is not under the Kotpa Act. And we are facing that in Delhi, most of the eateries, restaurants have the herbal hookah. This is the challenges. Thank you.
So this is to answer your point. So in around 2015, so Rahul Dravid was used as a role model for tobacco-free ads, and there were his ads would come movies se pehle. And the whole point of that was that he was not a user of tobacco, and he was seen as a role model. So the hope was that they would connect to the youth. Obviously, it's youth from a different generation. You still have people who maintain healthy lifestyle. So if you can tap into that, because youth is influenced by influencers on Instagram now, or film stars, and those who do abstain from tobacco use, they can look up to them as role models. So that's why we thought that is an additional component that can be utilized now.
Yeah.
Abhinav Bindra, like such sports person, we should be treated more like actors, not these Amir Khan and Shah Rukh Khan and all.
That was gathered including Instagram influencers and sports people, TV or OTT actors.
But altogether, what I feel is all of them, whether it is a sportsman, sportswoman, or a actor, or anyone, it may be even a YouTube short film makers. Everyone comes in a category as celebrities. That is what is branded. So celebrities are always there in any platform. So it is up to us whom we take as example and what the government can give approval about.
A small suggestion and addition to that, always we just focus on the champions who already come from de-addiction center and they are not using the tobacco. We can use them as a celebrity for this toffee program so that we can improve that one and we can give the examples of them to the students. Thank you.
Okay, thank you. So any other comments from Bari, Sumit?
It was a good presentation. The one in the model, the health belief model, I think that has some sort of thing has been shown. And in case of tobacco, I think there is an issue of perceived severity. So we have been trying various tools, be it a picture, be it warnings, but that has to be addressed with some sort of intervention, behavior intervention. Thank you.
Just one last comment overall in not only for this particular one, but I think all of you have made very good proposals in this fact that if we can further develop them and use them wherever you can get a chance, either in the
As long as you don't ask us for
as
money,
long
there's
as you-
everything is-
not only, I mean, maybe could be some possibility for funding from somewhere, but at least, don't let it end here. Maybe you can develop these further and we can work together and see. how
And also you can multi-site study. Okay, you want a group? Fine. Then we will go to the last session. Yeah, this is also a big group. Okay.
Thank you. Good
work. So now we go to the last session. And we'll be very quick about it. I think my team has a video to show of the different days events. Is it right?
Yes, sir. So we can walk through the memory lane of this workshop.
They've just created a sort of, yeah. Huh? Thank you. Okay, good. So we now go for the, I think all of you have been given Google Forms for giving your feedbacks, right? So please give good means not crazy, good feedback, appropriate, right feedback. Now I want only negative feedback. So anybody who wants to give something negative about the workshop should stand up now and say. About, yeah, we have to rethink about the
Yes.
hybrid mode. Agreed.
Because many of the speakers were also on hybrid mode. So that was a greater challenge for this particular subject, maybe because this subject needs a direct interaction.
Yeah, we
So,
realize that
yes.
that faculty who is present here interacts much better.
Yes.
Next time, every one of us will carry glass bottle rather than avoiding plastic. Every bottle takes 2 liters of water to hold 250
that was
ml
been
of water.
told to us again. I think
That's a
that
very
we have to
good
work
point.
within the place where we, these things are decided by the place where we hold.
Next time, sir, I am saying.
But yes,
this.
But we can actually.
yeah, yeah, we should be doing this. Agreed.
Only observation that some of the slides were not busy ones.
Yeah. Especially for people at the back.
Daily activities are made into group works. So instead of after 4 days and you are giving a task, so even we can do with whatever presentations are made on that day as a recap for the next day morning or end of the day. That can also be worked out, sir.
So we are discussing stars and champions. So star पता नहीं मैं हूँ कि नहीं celebrity, but champion तो definitely Mr. Jagannath Reddy है. Actually, in the first edition, we took participants to Balabgarh and our area, but it takes
because the observation is
almost a whole
based,
day for it. So that is something that we have to judge. Is it worth the whole day?
according to feasibility. Feasibility if possible.
Yeah.
Sir, first of all, in such a way that we have 1 day for field activity.
We could see something like that.
Sir, thank you for the 5-day NCD marathon of NCD symposiums. So, sir, as I want to add the point what he said, sir, despite I gave feedback continuous 3 days saying that the slides had to be given on the time of, because it was not visible from here and it won't serve the purpose for that session. So, and the day one I found that lots of overlaps were there. So I request the organizers to scrutinize the slides. So other than that, it was fantastic.
Overlaps between speakers.
Yes, sir.
Content also.
Yeah.
Only on day one, sir. Thank you.
Because day one, everybody talks about burden, blah, 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 same thing.
No, to contradict.
Discussing about each other. We are also discussing on many of these issues, but still.
To contradict his part about the presentations to be shared earlier itself, I don't think so. The participants are there to see only the slides. Basically, you see the slides, you'll miss the content. Always, you don't want to read the books. Books are okay, fine. We wanted to go with the books, but even the presenter is important who is presenting the concept to understand. We just go by the presentations, all the PPTs prior, and then it is there in our hand. We don't feel even to sit in that class, maybe that session. So it may be sometimes it's not that good to share all the presentations at once.
Sir, I would like to add on few feedbacks. First of all, we were here as an offline participant. Even then, we were attending it in an hybrid mode, which I think was, in a bit of a sense, not justified for me. Because when we interact with the speakers in an offline mode, we have a more connect rather than seeing some pre-recorded session. I think that we should take care of in the next and subsequent session. First thing. Second, it became a bit hectic sitting here from morning to evening. So mobility break ek do zyada ho sakte hain. Apart from that, being a resident coming from a hostel, and I think breakfast bhi thoda hota to thodi energy mil jati.
That's it. बताओ mobility break में जब हमने mobility break दिया कितने लोग ने mobility किया उसमें, कितने लोग ने चाय पिया और ये पे mobility तो किसी ने नहीं किया.
I think one thing is because there have been a lot of questions. I think ensuring that there is that time for questions, maybe grouped after 3-4 sessions, so that if there are sessions which have a lot more questions in comparison, because otherwise it just pushes things and 1-2 sessions get missed. So it may be better to group them or even allow the participants to reach out separately over email or whatever to the speakers, so that their questions are still answered as well.
So I personally felt that hybrid mode is the best mode. It has more benefits than there are some issues, technical issues, but we get a lot of exposure through hybrid mode. Not everyone can be physically present, so everyone is very busy considering their higher position. So hybrid mode opens a lot of opportunities to learn. So that is my personal opinion.
So there are some online.
We actually thought about it. पैसा नहीं था हमारे पास. नहीं तो dinner का plan था हमारे पास. There was a plan to have dinner.
So online candidates, do you have any issues and challenges that you want to share with the team? There have been quite a few, so it will be great if you can do it yourself.
Hello.
Yes, you are audible. Please go ahead.
I have one observation regarding the sound quality. An issue, I think. In between, the sounds are very low or voices are breaking. And another thing is, I think that the hybrid mode is a very good concept, because main aim of this kind of activity is impart knowledge, sharing knowledge. Everyone cannot be present in one location for 4 or 5 days. I think hybrid mode creates an opportunity to share this knowledge to a wider audience. I think it is very good concept and it should be continued. This is my observation.
Opinion is divided on hybrid. Is it good or a bad? Anyhow. Yeah, I know. I get it. But that's the point that he made. Many presenters don't have time to come and go. So then they present. So again, that's a trade-off, no?
I have no objection.
There is no right answer for it. There is no right answer for it. So let us not. Both of them have their advantages and disadvantages.
His suggestion only for pre-recorded videos.
Okay. Yeah. We didn't have too many of them. Maybe two, three only we had. Equity and that Shankar Pinja and
Pratima.
Yeah.
That would have been nice if she was
okay.
Sir, one more thing.
Yeah.
It's my opinion. I don't know how many will agree with this, because NCDs, we are towards NCDs and we are in intervention modes. I think some interventions would have been discussed here in this platform, rather than everything became subjective. Some interventions which are happening in India and in some of the districts, as you presented yourself, one of the project what you have taken in Faridabad. In that way, these some of the other things would have been involved in this. That studies would be great help for the students also in the perspective of more research view. That is my opinion. Best practices.
Okay, any message from the organizers that something you liked about the participants or did not like about the participants? Maheshwata and Abhishek.
You were very patient with all the technical glitches and the problems that we were suffering. But yes, a new place and this hybrid mode will be an issue as far as we are going ahead. But then it's also an answer, as everybody knows. More people can get together or come to the platform. But as we move ahead, maybe things will get smoother and sorting it out will be easier. But it was overall, it was great to have wonderful participants. Thank you. And Abhishek has lots to say. He was the main person suffering the brunt.
Sir, I just like
लिखा लगता है मेरे को।
Sir, I just want to say it has been an amazing 4.5 days of knowledge sharing sessions, and we had an opportunity to listen to and interact with stalwarts of their respective fields. And we had a great mix of participants from residents, doctors to state nodal officers to faculties and CVHOs. And this platform has been thoughtfully weaved by the planners, wherein we have walked through from vision to action. And hopefully this workshop has been successful to provide all of us with enough for thought. And we have the knowledge, and with the walk, all of us pledge to act on it too. And sir, I would like to extend my thanks on the behalf of all the participants to Anand sir, Dr. Bari, Dr. Sumit, Dr. Harshal, and all other all other faculties for bringing us together to this interactive workshop. And at the end, I would like to thank you for bearing with me.
Okay, so we know any concluding remarks from you, Bari? Then we distribute certificates.
No, nothing, but just really I appreciate the patience and the cooperation that we have seen by all of you. I know there have been a lot of glitches, especially on the first day. And we also realized that the sessions were very packed, back-to-back sessions. But despite all that, I feel that the attendance has been really good consistently, and none of you had really had any major complaints, though we had expected that. I mean, for us also it's a learning conducting this kind of a hybrid session for the first time. We did face some challenges, but thanks to all of you for your cooperation, and also for the online participants. Thank you for being there for the 5 days. I think it's difficult. It has been difficult to just keep logging on for 5 days, but yeah, we appreciate your presence throughout the 5 days. Thank you, all of you. Thanks.
Thank you from my side. I think we had very good participants, especially especially appreciate the state and district nodal officers who have come spend time. It is much more difficult for them to do this kind of workshop. I hope you have learned something and you can go back and use many of these in your own domains. Thank you. Now we can distribute these certificates. We can do it faster. We just give it to there, or do you want a formal distribution of certificates with photograph? Okay.
We want photograph.
I know.
Okay, so we have to go down.
Oh, no.
I'll do the first.
Yeah.
I'll do the first half. I mean, first one.
Dr.
ऐसा
Abhishek
कर
Garg,
सकते हैं, तुम दो लोग चले जाओ, आधा निपटा दो, हम दो आगे चले जाएं। 2 लोग रहेंगे तो बीच में फोटोग्राफ भी अच्छा रहेगा। हाँ, हम पीछे से हट जाते हैं, फोटो बॉम्बिंग नहीं करते। नहीं, Sumit, you be on the other side. No, participants should be in the middle. No.
thank you for attending.
Alisha Raj. Alisha Raj.
Okay, next.
Anam Alwani. Anil Koparkar. Yeah. Anjusha Ranjit. Ankit Chandra. Varsha Priyadarshini. Varsha.
You announce the next. So that the next
Cecilia Mary. Cecilia. Deepak Jaiswal. Deepika Khaka. Deepika. Ebenzer.
50% पे रुकने हमारे अच्छा उधर भी है मुझे लगा इधर खत्म हो गया
Girish. Anspreet. Emmanuel. Ishani. Jagannath. J. Vinodni. Ajal Taluja. Karan. Kumaraswamy. Lalit. Lata. Lavanya. Okay. Lavanya. Manoj Bajaj. Manoj Patrun. Nitesh Shah. Be sharing the link of this photograph so everybody can have a good memory of this workshop. Anand. Pawan. Pragya Pathak. Pragya. Preeti Tanwar. Priya Sharma. Pritam. Pritam. Priyanka Bande. Arvel Murugan. Arvel Murugan. Rajalakshmi. Rajalakshmi B. Rajendra Kumar. Rajendra Kumar. Rajratan. Rajratan. Reena Kumari. Reena Kumari. Sanjay Singh. Satyakani. Sangraj. Shivangi Das. Shambhavi. Shambhavi. Shikha Bhasin. She has been missing on her cousin's Mehendi. Thank you, Shikha. Sonali. Sonali. Soni Kumari. Soni Kumari. Srinath. Srinath. Shruti. Shruti M. Shruti. No. Sucheta. Somna. Swarnlata Das. Anya Khanna. Udita Singh. Vinod Power. I hope we've not missed anyone.
Let's have a
Yeah, we can. We'll not show the name. We'll not show the name on it. Please don't zoom on the name, please.
If there's a blank certificate.
Anyone else? So online delegates, we'll be mailing you your certificates. Sorry that you missed the photograph.
Let's go for lunch.
So we break for the lunch and online delegates can have a quick lunch in the restaurant. Okay, then see you all.
Okay.
We are leaving the Zoom. Thank you all the online delegates. See you again in the next workshop. Thank you.